It's a pleasure to be here to be presenting on the updates in CL psychiatry. My name is Dr. Sanjeev Sokalingam. I'm a CL psychiatrist at the University of Toronto, a professor and vice chair education, and also the vice president of education and a clinician scientist at the Center for Addiction and Mental Health. It's my pleasure to be presenting on advances in eating disorder care, an update for CL psychiatrists. I want to start off with just my disclosures. And again, some of the work that I'm going to be presenting reflects some of the psychological and virtual treatments in binge eating that I've done that have been funded by CIHR in Canada. And I'm an associate editor for General Hospital Psychiatry. What I'm hoping to cover over the course of the next 30 minutes is really an overview on anorexia and bulimia nervosa, looking at indications for more acute treatments, especially as CL psychiatrists, seeing patients in the inpatient setting and when they need more immediate care, some initial treatment approaches, an overview of treatment guidelines. I'll also touch on some of the more complicated scenarios related to compulsory or involuntary treatment for anorexia nervosa. And then I'll also switch and talk about eating disorders and treatment in the context of obesity, specifically binge eating disorder, night eating syndrome, and eating disorders after bariatric surgery, given how common bariatric surgery is over the last decade. So with that, I'm just going to start off with an overview of the eating disorder diagnostic groups. We know, again, anorexia nervosa, bulimia nervosa, and binge eating disorder are the kind of primary diagnoses within this cluster of categories within DSM-5. Anorexia nervosa has severity criteria based on BMI, with BMIs less than 15 indicating more extreme or extreme in terms of severity of anorexia nervosa. We also know that thresholds for binge eating have changed with DSM-5, going from a minimum of 2 per week to 1 per week, which also impacts diagnosis and prevalence. And there are other eating disorders like avoidant restrictive food intake disorder, which is very similar to anorexia nervosa without the body image or concerns about one's physical appearance, as well as what we call OSFED, which are those that are kind of atypical presentations of anorexia nervosa, purging disorder, or night eating disorder. And I'll cover some of these in the subsequent slides. My main focus will be on anorexia nervosa, bulimia, and binge eating disorder, as they are the most common amongst this group and the ones where we have the best evidence and research to guide us. There's been a lot in terms of lifetime prevalence rates of eating disorders. This lifetime prevalence rate is from 2018 epidemiologic data. You might say these rates look a little less than what we usually think about. I think it's important to note that we are looking at both males and females in the general population and looking at these rates, whereas we see higher rates obviously in females, especially in the categories of anorexia nervosa and bulimia nervosa. We may even see rates of anorexia kind of creep between over 1% to 2% in bulimia nervosa as well. And we know binge eating disorder can be higher in certain patient populations as well. Interestingly, important to look at rates of seeking for help for eating disorders. We see that patients with anorexia nervosa are less likely than, say, bulimia nervosa, which is the most, and binge eating disorder to seek treatment, which is really panned out over the last 5 years in terms of data. We also know prognosis is different, with anorexia nervosa being the most difficult to treat, really 40% making good recovery after 5 years, bulimia slightly better, and binge eating disorder having a better prognosis than the other two. In terms of what to do, there are screening tools that are often used, many rating scales for various symptoms, including eating disorder psychopathology, but this is a great screening tool that's been often used in primary care settings. That's the SCOFF screening criteria. So do you make yourself sick because you feel uncomfortably full? Do you kind of worry that you've lost control over how much you eat? Have you lost more than 1 stone? And this is from the UK, so I've converted there 14 pounds over a 3-month period. Do you believe yourself to be fat when others say you were thin, and talking about that body image distortion? And would you say that food dominates your life? And if you have a score of 2 or more, it is a kind of more sensitive and likely a case of anorexia nervosa or bulimia that warrants further investigation, exploration on history and psychiatric assessment. I think one of the things that's apparent in why CL psychiatrists are often involved in the care of patients with eating disorders in the context of anorexia nervosa are the multitude of medical or physical health complications that are associated with anorexia nervosa, specifically more severe anorexia nervosa. So cardiac abnormalities such as arrhythmia, including bradycardia or tachycardia, increased QTc prolongation, hypotension, people who use ipecac as part of their compensatory behaviors might be at risk for cardiomyopathy or left ventricular atrophy. We see endocrine disorders that might emerge as a result of that. Amenorrhea used to be part of the criteria, but is a common complication with significant weight loss in the context of anorexia nervosa. Hypoglycemia, poorly controlled diabetes, and there's literature about individuals with type 1 diabetes and anorexia who often underdose their insulin to lose weight, which can precipitate severe hypoglycemia or DKA in the context of these complications. Electrolyte abnormalities, hypokalemia, hypophosphatemia, or low magnesium, or a low sodium or chloride as well. Acute pancreatitis or Mallory-Weiss tears, or esophagitis, the latter two from a result of kind of purging behaviors. And people who are purging might have enlarged parotid or salivary glands as well. We also see some elevations in liver enzymes or low albumin. And then other features, which include kind of osteopenia or osteoporosis from kind of poor absorption of nutrients and placing individuals at risk long-term, as well as other physical signs like brittle hair, lanugo hair, or dental erosions, again, or dental erosions resulting from purging behavior. I think it's important when we think about patients with eating disorder, whether we count them on outpatient settings or inpatient, to think about what is the model of care that they require, whether it's an adult or a youth. And we can think about this in 3 categories. Outpatient, often thinking about patients who are more medically stable but require a multimodal intervention. Day treatment, which is that intermediary phase where we have individuals who might need more intense treatment than an outpatient team alone. And then inpatient treatment, especially those that will be medically unstable. And again, when we're getting consulted on the medical wards for patients with more severe anorexia or bulimia, we should really focus on what's the most limited intervention to preserve life at that moment. Is it inpatient treatment because it's early on or more severe prognosis in terms of stabilization and they require inpatient treatment, or are these patients that could benefit from day treatment or outpatient treatment based on their medical severity? And so these are some of the indicators for criteria for medical admission. They are outlined in the APA eating disorder guidelines. The Australian guidelines have very similar criteria as well, but you can see significantly low BMI, less than 12, kind of really rapid weight loss. There are some systolic blood pressure cutoffs of less than 80 or significant drops or postural hypotension, specifically greater than 20 millimoles of mercury drop from standing. Heart rate, so we think about bradycardia that's severe or tachycardia or postural changes. Again, hypothermia being another one in terms of the body temperature. Arrhythmias for sure are another criteria. I mentioned electrolyte and blood sugar abnormalities, renal dysfunction, or significantly low albumin or markedly elevated liver enzymes. All of these are considered as part of the criteria for medical admission on an inpatient setting for more acute eating disorder treatment. And here is a checklist, again, that's been around for a while, developed in the UK, that really takes into account kind of reminders on how we might assess patients who are very ill from anorexia nervosa, assess the need for refeeding, really quick reminders and what we need to monitor, and then management in terms of team, the expertise of the nursing staff, and any high-risk behaviors that are needing to be managed in the acute setting. So a very useful tool for clinicians. In terms of treatment, again, these guidelines more recently from Australia have actually outlined level of evidence. There is this reference at the bottom by Hibbert and colleagues that actually looked at all major guidelines in Europe and North America, as well as in Australia, to look at common themes and really reinforce these level 1 interventions for treatment. So one, family therapy, particularly there are interventions from the Maudsley that have been used to really intervene and help stabilize patients with anorexia nervosa, so it improves eating disorder symptoms and weight. Individual psychotherapy, either CBT or interpersonal psychotherapy, also has level 1 evidence. There's been a lot of interest in antipsychotics capitalizing on the weight gain with, for example, olanzapine. And although there are some initial studies, not enough robust evidence to recommend it as a level 1 agent. We know that there have also been agents for antipsychotics to look at eating disorder symptoms or improving mood or reducing kind of ruminations related to food. Again, inconsistent results to justify antipsychotics as a level 1 intervention. And antidepressants, in fact, have not shown significant benefit for improved weight gain or relapse prevention. And really, there's a lot of conflicting evidence, and in fact, studies suggesting that in patients that are severely underweight, that antidepressants have limited effect. In terms of treatment of bulimia nervosa, individual psychotherapy, again, we know that cognitive behavioral therapy or enhanced CBT, that's CBTE, by Fairburn and colleagues, is a level 1 evidence for both reducing eating disorder psychopathology and binging. IPT has level 1 evidence, but slightly weaker in terms of the number of studies than CBT. And dialectical behavior therapy also has some level 2 evidence. Family therapy, again, not as robust as in, say, anorexia nervosa, but also has some evidence for binge eating and reducing eating disorder psychopathology. Antidepressants actually have better evidence in bulimia nervosa, especially for binge eating symptoms in the context of combined psychotherapy. And again, SSRIs tend to be the mainstay of these studies, particularly fluoxetine. And there is some conflicting evidence about their effect on relapse prevention. And then mood stabilizers, topiramate has been used for binging and purging and quality of life. And although the evidence is there, we often do not tend to use it as one of the earlier interventions due to cognitive side effects associated with topiramate. I will say for antidepressants, bupropion is not one that we would use for patients with bulimia nervosa. As you may recall, the initial studies around seizure risk came up in a patient population with bulimia nervosa, and so we would avoid this medication for this patient group. One of the more controversial and challenging situations is what to do when patients are admitted to medical wards or emergency departments due to significantly low weight and severe symptoms of anorexia nervosa, and the issue of a patient not wanting to seek treatment but being at significant risk, and what are our obligations or our role for suggesting involuntary commitment for treatment. And these are 3 questions that are very helpful. One is, does the patient have capacity to refuse treatment? Something we need to assess as well. Will hospitalization help the patient? And again, we think about course of treatment. Factors that might influence people who might be considered for involuntary treatment are usually people with more severe eating disorders, significant psychiatric comorbidity, or an illness history. And maybe those that are shorter illness might be more likely to benefit from those involuntary treatment because they could get better quicker, which might have a better long-term prognosis, as to someone with more refractory symptoms whom hospitalization has showed limited effect. And the last question is, what is the impact of involuntary treatment on patients and their autonomy? And I'll talk a bit more about that in the subsequent slides about engagement, impact on care, and therapeutic alliance. We know for capacity, the first question that I had raised related to anorexia nervosa and involuntary admission, that in studies that have looked at mental capacity in patients with anorexia nervosa, a mean BMI of just over 15, almost a third of patients were identified as having diminished mental capacity, usually associated with lower mean BMI, previous hospital admissions, and more previous eating disorder treatments, really a severe course. And this again occurred in this range of 13 to 44% of anorexia nervosa admissions. Poor mental capacity is associated with higher admission rates. Poor remission rates and deficiencies in capacity might persist even after weight restoration has occurred, including for several weeks to months after. Evidence suggests that anorexia nervosa abnormalities in emotion regulation might relate to serotonin and dopamine dysfunction in the mesolimbic system. And so that might impact a patient's capacity in terms of the interplay of cognition and emotion disturbance and the influence on decision-making. And the effectiveness of involuntary commitment is still early in its research, although there has been some interest over the last 10 years or so. Detained patients that have more severe anorexia nervosa symptoms, higher comorbidity, and longer duration of inpatient stay might be detained in an inpatient setting as a result of this. And it's been maybe beneficial in the short term with respect to remission, but long-term outcomes remain unclear. And there's really no conclusive data or studies on long-term outcomes or reductions in mortality, which are quite high for patients with anorexia nervosa. And so a 5-year follow-up study of 162 patients showed higher mortality in compulsorily admitted patients versus voluntary, although again, that was one study of 162 patients in a specific context. So again, we have very limited literature to guide us. I would also say that patients experience, those patients living with anorexia nervosa who underwent compulsory treatment identified that compulsory treatment was necessary when their anorexia was life-threatening. And they actually also disclosed that even in voluntary treatment, they felt coerced. And also some of the data that we've seen in this study and others, that compulsory treatment has not been associated with poor therapeutic engagement. So, patients, we don't see a lot of impact on the therapeutic alliance, but for patients with anorexia nervosa, they may in fact see benefits after they've been in treatment on an involuntary basis. And that being said, this is something that needs to be assessed longer term and of course, over the course of one's admission. So I'm going to switch now from anorexia and bulimia nervosa and talk about obesity and eating disorders and a bit more on binge eating disorder. I will say this is data from patients who were being assessed at a bariatric surgery center, one in a European study in Germany, one in the US, independent of the actual clinic, and actually showed high rates of psychiatric illness as per a SCID assessment. 2/3 of patients had a lifetime history of a psychiatric illness, mood disorders being quite common, as well as anxiety disorders. But we do know that eating disorders, mainly binge eating, was one of the more common disorders amongst the top 3. We know for binge eating disorder, again, I talked about prevalence rates and talked about kind of the criteria changes with DSM-5. There is mounting evidence of the efficacy of CBT and to a lesser degree, but still robust in terms of interpersonal psychotherapy for binge eating disorder. It's effective in reducing disordered eating behaviors, improving kind of some of the cognitive components and improving mood. We haven't seen kind of a substantial effect on weight loss in patients who are living with obesity or are overweight and have binge eating disorder. One thing to note, though, is in many places, CBT specific for binge eating disorder may not be accessible. And there have been studies looking at guided CBT. it does have level 1 evidence and is a reasonable alternative to CBT, including some randomized controlled trials that have shown, although it's not as robust in its effect size compared to in-person or group CBT, guided CBT still has some benefit and can be result in effectiveness in the proportion of patients with binge eating disorder. Second-line treatments include dialectical behavior therapy, although there needs to be further evidence. And again, if we're targeting weight loss, behavioral weight loss therapy is first line in combination with other treatments for binge eating disorder. In terms of pharmacotherapy, we know that lisdexamfetamine is approved. Antidepressants, we know that there are meta-analyses that have shown that antidepressants are very close in terms of effectiveness for binge eating disorder. No clear difference between antidepressants types, but again, if a patient is presenting with depression and binge eating disorder, you might opt for the antidepressant first before going to lisdexamfetamine. Lisdexamfetamine has better evidence for more days abstinent from binge eating disorder than antidepressants. And topiramate, as I mentioned before, in bulimia nervosa also has some effectiveness in binge eating disorder, although side effect profile is a limiting factor. And we do see the emergence, given the comorbidity of obesity and binge eating disorder, of using weight loss or anti-obesity medications. So liraglutide is one agent. A single randomized control trial showed reduction in binge eating when combined with intensive behavioral therapy. And naltrexone bupropion, another agent, a single pilot RCT showed reduction in binge eating when combined with behavioral therapy. So again, we do see some emerging treatments to treat both the physical health consequences of binge eating disorder, like obesity, as well as the binge eating symptoms themselves. I'll talk about night eating syndrome or night eating disorder, which, as I mentioned, is one of the kind of OSFED or other types of eating disorders in DSM-5. There really is characterized by eating at least 25% of your food intake in the evening, or at least 2 episodes of nocturnal eating per week. People have to be aware and recall this. And there are associated symptoms, at least 3 of the following. So morning anorexia, so they don't want to eat in the morning, at least 4 or more mornings per week, a strong urge to eat at night, insomnia, a belief that there's a need to eat in order to sleep, and mood changes that are often worse in the evening. A significant component is distress or impairment in functioning and has to last 3 months or longer and can't be accounted for by another condition. We know there's quite variable rates because the definition of night eating syndrome really depends on either clinical assessment, but many have used self-report scales. There's a higher prevalence in patients with obesity or who are overweight, and even higher in bariatric surgery candidates who might be having higher, more severe obesity when they present. And again, there is comorbidity with binge eating disorder. In fact, we did a study that showed loss of control over eating was a common symptom across binge eating disorder and night eating syndrome. And how we distinguish it, someone presents with evening hyperphagia, night eating is on the differential, but we need to rule out binge eating disorder, or if there are compensatory behaviors, bulimia nervosa as well. And if people are sleeping and then wake up in the night to eat, we just want to make sure, again, they're awake and can recall things. Whereas parasomnias or sleep-related eating disorders, often patients will not remember waking up through the night. And in fact, will wake up in the morning, or their partners will comment on food in the bed or in the kitchen that the patient will not recall. So really that recollection is critical. And again, we make the diagnosis when there's distress and impairment associated with it. In terms of treatments, very limited evidence for night eating syndrome. Again, as you can imagine, not as well defined, and as a result, not as many trials, but some SSRI trials that are very small in terms of their sample size have some positive or mixed results. Some case reports for topiramate, melatonin, or light therapy as some circadian rhythm abnormalities have been associated with night eating syndrome. But CBT is one of the more promising treatments for night eating syndrome, and there are self-help books and manuals related to targeting this particular syndrome. I'll just end by talking about bariatric surgery and eating psychopathology. The two most common kind of bariatric procedures now, the lap band has fallen out of favor, but the Roux-en-Y gastric bypass, which is kind of malabsorptive and restrictive procedure, a sleeve gastrectomy, which is a bit more restrictive, are the probably two most common types of surgeries. And it's interesting because after surgery, and it's a treatment for severe obesity, that we tell patients to restrict their food portions, avoid high fat sugar foods, avoid kind of getting that dumping syndrome afterwards. We tell them to chew food extensively, be vigilant about calories, weighing to monitor and self-monitor. They experience rapid weight loss, especially in that first year after the procedure. If they eat too much, they might vomit after eating and sometimes can develop food intolerances. If you look at this list, it is in fact probably suggestive of an eating disorder in its own, or abnormal eating patterns if you didn't know that this patient had bariatric surgery. So again, it is this concern that in fact, although we recommend this as part of the regimen after bariatric surgery, it is something to consider that some patients may have more severe forms of these behaviors that might look like an eating disorder. In fact, we have been trying to monitor and determine the prevalence rates of eating disorders after bariatric surgery, and anorexia nervosa, although there are anecdotal reports, we don't really have large prevalence studies. Bulimia nervosa, about 3% meet criteria when they come to surgery, before surgery, but we don't actually have rates afterwards. And binge eating disorder, for some patients, the surgery can actually treat or reduce binge eating disorder symptoms, but the rates range post-surgery from 0% to 10% in certain samples. And really it's determined by how one defines binging after, because objective binges after surgery are hard given the smaller stomach pouch size. And then grazing behaviors or uncontrolled type of eating behaviors are probably more common, up to 50% in patients after surgery. And we know that it's important to monitor for this because eating disorder symptoms after surgery are a predictor of weight regain. And so we want to recognize this and intervene. What's good though is we have emerging evidence that giving treatments upfront before surgery probably doesn't last in terms of its benefit after surgery and reducing outcomes. There is some evidence that suggests that patients who respond to binge eating treatments like CBT and have reductions in their binge eating before surgery might fare better longer term. But overall, prescribing CBT for everyone before surgery hasn't resulted in changes in the course of their symptoms afterwards or their weight loss trajectories. Really, the intervention is good assessment for bariatric surgery, ensuring that patients are stable and engaged in treatments as part of the bariatric surgery preparation, not anything necessarily intensively above that. And that they're not having severe or uncontrolled eating disorder symptoms. That would be a concern for bariatric surgery, but it's really after surgery that we recognize early symptoms of eating psychopathology and intervene with psychological treatments. And CBT, we've done several studies with virtual treatments of CBT like telephone and other that are helpful and shown reductions in emotional eating, binge eating, and even mood and anxiety. And there's emerging literature for mindfulness and acceptance-based therapies as well, which are again, are also been beneficial for bariatric surgery patients with eating psychopathology. I just want to say before I end that there are additional resources. This is an APA resource document that highlights bariatric surgery, psychiatric care that might be beneficial as well. And so with that, I just want to summarize that eating disorders remain a challenge to treat. We do know that certain populations may be at higher risk, and a multimodal approach with appropriate triaging to medical, inpatient, and outpatient services is needed. Obesity is also associated with several eating disorders, namely binge eating disorder and emerging kind of recognition of night eating syndrome. Surgical treatments for obesity warrant long-term follow-up because eating psychopathology is a poor prognostic factor for weight loss and quality of life after bariatric surgery. And we do need further research, including better research on pharmacotherapy and its role in the management of eating disorders. So I'd like to stop there and just thank you so much for listening. If you have any questions, please reach out to me. I'm happy to provide additional resources or responses to any of your questions. Thank you.
Hi, I'm Sarah Andrews from Johns Hopkins University, and I will be starting our substance abuse update, followed by Dr. Robert Weinreib from University of Pennsylvania. We will be discussing trends and updates on several substances, including illicit drug use, as well as liver transplantation for alcohol-associated hepatitis. Background information, including incidents of use, as well as updates and research trends for marijuana, psilocybin, and alcohol will be described. I have no relevant disclosures. The two substances that I will be discussing are marijuana and psilocybin. The first objective will be to identify trends of marijuana use, including the current state of legalization of marijuana. We will also evaluate the positive and negative effects of marijuana use. We will then review the history and background of psychedelics, specifically psilocybin. We will describe the current research regarding psilocybin in treating psychiatric illness. We will start by discussing marijuana. We will discuss background information on marijuana, following the trends of use, legalization, and end the discussion on positive and negatives of marijuana use. Marijuana comes from dried flowers of cannabis sativa. Both marijuana and hemp are derived from cannabis sativa. There are several differences with hemp and marijuana. With hemp, it is divided with either seeds or CBD. The seeds are consumed whole or processed in a variety of beverages or foods. There is no physical effects of seeds since hemp is not psychoactive. Hemp in seeds is legal as long as there's less than 0.3% of THC, which has been in place since the 2018 Farm Bill. For hemp CBD, it's consumed through chemical compound extracted from lilies or flowers. Again, there's no physical effects since hemp has no psychoactive components. It's legal to possess CBD hemp, but it cannot be added to food or topicals. Marijuana can be in the form of flowers, trim, or CBD. Flowers and trim can be whole, ground, or turned into hash or concentrate. It can then be smoked, vaped, or eaten. Flowers and trim contain THC, which is the chemical compound that produces euphoria. THC, the chemical found in the resin produced by leaves and buds, primarily in the female cannabis plant. In regards to legal status, marijuana is federally a Schedule I drug, but legal for medicinal recreational use in many states. The other form of marijuana is in CBD, which is the chemical compound consumed by smoking, extraction, or inclusion. CBD alone does not cause euphoria. In regards to legal status, it all depends on state laws. Marijuana use has been holding steady over the years, which is typically defined as the flowers and trim for marijuana with active THC. Marijuana is by far the most popular drug in the US as well as in the world. Approximately half of Americans, nearly 78 million people, have reported using marijuana at some point in their lifetime. 12% of Americans have identified themselves as current users based on the most recent Gallup poll from 2019, which has decreased from 2016 at 13%. From 2013 until 2016, the rate of marijuana use nearly doubled, but since then, the rates have been remained fairly steady. In regards to specific trends in marijuana use, the group with the highest percentage of marijuana use are Americans ages 18 and 25 years. In the last month at 22%, the last year at nearly 35%, and lifetime almost 52%. Men are also more likely to smoke marijuana than women. In 1996, California was the first state to legalize medical cannabis. Since then, medical cannabis has been spread to the majority of states, including 37 states, 4 permanently inhabited U.S. territories, and Washington, D.C. In 2012, Colorado voters approved a ballot initiative to legalize the recreational sale and use of cannabis, which was the first state to do so. Now, 17 states, including Washington, D.C., have fully legalized marijuana, both for recreational and medicinal use. Of note, every cannabis related ballot measure in 2020 passed, including medicinal and recreational bills. Following this past election, when President Joe Biden and the Democrats took control of the House and Senate, ongoing conversations of legalization of marijuana continued. Currently, 1 in 3 Americans live in states where marijuana is legal, and the remaining states are facing pressure to legalize. Even those that have not legalized medicinal or recreational marijuana, most have decriminalized marijuana. Only 4 states currently have made marijuana completely illegal. Over the last several decades, Americans' view on legalization of marijuana had become more favorable. From 1969, based on the Gallup surveys, 12% of Americans were in favor of legalization of marijuana. By 1977, the support had nearly doubled to 28%. Over the last 2 decades, the support of legalization has significantly increased. Currently, nearly 70% of adults in the United States are in favor of legalizing marijuana. Marijuana is also widely accepted as being less risky than other substances such as prescription opiates, alcohol, and tobacco. For example, over 70% of Americans report that alcohol use is more of a health risk than regular marijuana use. Three-quarters believe that marijuana is less harmful than tobacco, and over half of Americans believe that marijuana is socially acceptable. Much of this increased acceptance of marijuana relies on the assumption that DEA has never reported any overdose deaths related to marijuana use. With nearly 12% of Americans as active marijuana users, nationwide cannabis sales have increased by 67% in 2020, and the US cannabis industry is currently worth over $61 billion. Although the COVID-19 pandemic has been devastating to many industries, this has not been the case for the cannabis industry. 2020 was a record year since most areas remained open despite other markets, such as restaurants needing to shut down. Sales of medicinal and recreational marijuana products were both record highs in both the mature markets, such as Colorado and Oregon, for example, as well as the new markets. Analysts believe that in 2021 and even beyond, it will continue to grow. Despite the increase of regular marijuana users and acceptance of marijuana use, there are multiple common adverse effects of marijuana use. In regards to psychiatric effects, marijuana can cause increased risk of psychosis with repeated consumption of cannabis in vulnerable individuals as well as in naive users. Anxiety and panic attacks can also occur. Chronic use of marijuana is also associated with worsening mood as well as mania and depression. Cannabis use can also cause dependency in certain percentage of users, as well as withdrawal symptoms in some, including irritability. In regards to cognition, there can be cognitive impairment with intoxication, as well as increased risk of car accidents. The respiratory system can also be negatively affected. Acute consumption can decrease airway resistance, and chronic use can increase risk of airway disease and lung cancer. Although there's documented negative effects of marijuana use, there have been some studies outlining the positive medical benefits of marijuana. There's evidence of therapeutic effects of cannabis on some symptoms associated with neurologic disorders such as multiple sclerosis, MS, and chronic pain. Cannabis-based medications have improved MS symptoms, including appetite and central pain. However, there have been mild negative effects of cannabis on cognitive functioning of MS patients as well. In addition to MS, cannabis-based medications can have effect on some chronic pain conditions, such as cancer pain. However, THC side effects such as somnolence and ataxia make it more challenging as a pain medication. CBD, however, can offer some pain relief in patients without THC side effects. Although there is a large body of evidence that demonstrates negative effects of marijuana use on psychological functioning, there has been some research demonstrating therapeutic potential of cannabinoids, such as CBD, on mental disorders such as schizophrenia, depression, or anxiety. Similar to marijuana, which was once largely illegal with minimal support from the general population, psilocybin is now gaining more support from the general population with greater focus on research endeavors to demonstrate beneficial effect. We'll begin with background information on psilocybin, including origin and history. We'll then discuss current research and benefits of psilocybin. Psilocybin is a chemical obtained from certain types of fresh or dried mushrooms. Psilocybin mushrooms are found in Mexico, Central America, or in the United States. It's a class of hallucinogenic drug, and hallucinogens produce mind-altering effects known as hallucinations once ingested. Hallucinations typically create delusions, emotional swings, or feelings of detachment or derealization. Of all the psychedelics, psilocybin has one of the most favorable safety profiles. The history of psilocybin began over 6,000 to 7,000 years ago when the first magic mushrooms were used for religious use. However, modern scientific study of psychedelics started in 1922 when PCP was synthesized. 16 years later, in 1938, during what's called the first psychedelic renaissance, LSD was synthesized by Albert Hofmann in Switzerland. This discovery has been considered the beginning of molecular psychiatry. LSD was then marketed as a psychiatric drug for treatment of alcoholism, neurosis, criminal behavior, and schizophrenia. However, sales were halted nearly 20 years later due to side effects. In the late 1950s, Hofmann received a sample of magic mushroom from Mexico and convinced himself of the mushroom's bioactivity. He separated the extracts of the mushroom, In the 1960s, the Switzerland pharmaceutical company distributed indocybin TM, which was a pill containing about 2 milligrams of psilocybin. In the 1960s, recreational use of psychedelics became central to the hippie counterculture in the United States, which led to the United States Drug Enforcement Agency, the DEA, to prohibit psychotropic substances, including LSD and psilocybin, labeling them both Schedule I drugs under the Controlled Substance Act of 1970. This has since stigmatized psychedelics and has impeded research until recently. For decades, minimal to no research was conducted with psychedelics. Only recently, psychedelic research has become more accepted and widespread. In 2004, UCLA researchers started trials on psilocybin for pain, anxiety, and depression, which started what's called the beginning of the third psychedelic renaissance. From a 2006 publication from Johns Hopkins using psilocybin, this again sparked a new age for psychedelic research. In 2018, the FDA approved ketamine for patients suffering from treatment-resistant depression. And in 2019, breakthrough therapy status for psilocybin treatment for depression was granted. And in September of 2020, Johns Hopkins University founded the Center of Psychedelic and Conscientious Research. The study of psychedelics, specifically psilocybin, are rapidly gaining interest. Much of the interest lies in the recent clinical studies showing the ability to improve symptoms of depression after only a single treatment. As shown here, the chemical structure of psilocybin utilizes the 5-hydroxytryptamine 2A receptor, as does the classic serotonin structure. The FDA recently designated phase 3 clinical trials studying psilocybin to treat major depression with breakthrough therapy status. If successful, the use of psychedelics would be groundbreaking. Psychedelics may act as immunomodulators by reducing levels of pro-inflammatory biomarkers. There is so much more research necessary to determine exact mechanisms of action and interactions, including on the central nervous system and of any impact of neurodegenerative disease. There's been observational data and preliminary studies suggesting that serotonin 2A agonist psychedelics may have potential in treating various substance use disorders, including opiate use disorders. One study via cross-sectional and self-report methods demonstrated psychedelics, specifically LSD and psilocybin, reducing problematic substance use with 96% meeting criteria for substance use disorder prior and 27 meeting criteria after psychedelic use. Although self-report methods cannot determine if psychedelics can change drug use, these results show the potential for ongoing research needs in psychedelics for psilocybin-associated treatment for substance abuse. The many effects of magic mushrooms are dependent on species and concentration. For psilocybin, there's both psychic and somatic effects based on doses. These effects are based on the individual's mindset and body type, which include both weight and metabolism. Typically, there's a rapid increase in plasma level of psilocybin, followed by a plateau for about an hour, and then the level decreases until usually it's about 6 hours where it becomes undetectable. Subjective effects may last anywhere between 3 to 6 hours. Some of the psychic effects include stimulation of affect or affective activation, hypnagogic experience, dreams, increased ability for introspection, mystical type experience, and that's one of the most important elements, which predicts the success of therapy and the likelihood of the persistence of positive benefit of psilocybin treatment. There are also illusions and alterations of thought and time. Somatic effects can include multiple different elements, which includes a change of heart rate, change in blood pressure, nausea, changes in reflexes, and also tremors. In several different clinical studies, the subjective outcomes of psilocybin administration can be measured using different questionnaires after administration, which can include the Beck Depression Inventory or even the Mystical Experience Questionnaire. Studies have shown several different positive outcomes, which can include positive improvements in even personality, increased altruism, improved in connectiveness in others, decreased violence and criminal behavior, decreased suicidal ideation, and improved openness. One study even showed persistent improvement in mood and attitudes up to 14 months after psilocybin therapy. There's so much more need for research to discover the degree of psilocybin benefit in several domains. Listed here are just some of the few recent studies for psilocybin-assisted therapy. In addition to having potential to treat depression and anxiety, psilocybin has demonstrated evidence to treat substance abuse disorders, pain disorders, personality disorders, and even inflammation. Both marijuana and psilocybin are Schedule I drugs since 1970. Marijuana has since been legalized in the majority of states for either or both medicinal or recreational use, while psilocybin has started to be used for drug trials for treatment of several different psychiatric illnesses. In summary, 12% of Americans identify themselves as current users, and 70% of Americans are in favor of legalizing marijuana. There's been a strong movement towards legalization of marijuana. Similar to marijuana, psilocybin is a Schedule I drug. There's been greater traction towards research for psychedelics over the last decade, and even more funding in the last couple years. Psilocybin has been shown to demonstrate multiple benefits for psychiatric illness, including substance abuse. As our understanding with both marijuana and psilocybin has shifted over the years, our treatment for alcohol has also evolved. We'll now continue our substance abuse updates with a discussion on alcohol-associated hepatitis.
Well, hello, everyone. This is Bob Weinreib. I am coming to you live, sort of, from the University of Pennsylvania. And I just want to thank the ACLP organizers and Sarah Andrews for doing this presentation and inviting us to give it for you. This is part of the Substance Abuse and Use Disorders Updates course, and I'm going to be talking mainly about two different topics. First of all, I have no disclosures, there are no conflicts of interest or other things to disclose. The two topics will be, one is going to be liver transplantation for alcohol-associated hepatitis and short sobriety, and the other will be about stimulants, specifically amphetamines and cocaine. I'll start with topic number one, which is alcohol-associated hepatitis. In terms of the history of this, really this all became clear to the field of addictions as well as transplantation medicine after Matherin published a paper in New England Journal of Medicine in 2011 entitled Early Liver Transplantation for Severe Alcoholic Hepatitis. That paper was really a landmark study that legitimized transplantation for people with short sobriety. And so there was no fixed period of abstinence in this study that was required. It had to have been the first liver decompensating event for these patients, and they had to have failed medical management in order to be eligible, which is usually pentoxifylline and steroids in high doses. It was a highly selected population of only 26 patients who had alcohol-associated hepatitis compared to 26 matched controls. The justification for doing liver transplant for alcohol-associated hepatitis was based on a worldwide increase in alcoholic liver disease and the mortality that's been associated with it, especially in younger patients. We're seeing people now in the ages of 25 to 34 who are coming into the hospital with alcohol-associated hepatitis. Many of them have this superimposed on cirrhosis, and they need decisions about whether or not they can and should be receive a liver transplant in a very short period of time, sometimes hours. The thinking, I think, behind this was that, there are treatments available for alcohol use disorders, and we can make those available to patients if, in fact, they don't have a history of any alcoholism treatment. And in my experience, most of these patients don't. And another thought was that, well, if we're transplanting people with obesity or asking them to get gastric bypasses, as well as people who've made suicide attempts by acetaminophen overdoses, well, why wouldn't we consider this population, especially given the risk of dying if you don't get the transplant? So part of the justification, if not maybe all of the justification, came from this as well. There was a paper published by Asrani that detailed the outcomes of what's called the Dallas Consensus Conference. And this was published in Liver Transplantation in January of 2020. And it does a very nice job of describing the history and evolution of this change in the field. Basically, important to remember is that before people were doing these transplants for these younger patients in alcohol-associated hepatitis, the majority of these patients would not have been considered for transplantation even 10 years ago or even 5 years ago in most programs in the United States, based on the 6-month rule, which is not really a rule, but it was created in the 1990s essentially as a guideline for transplant programs to use to see whether or not patients would end up recovering from their liver disease and not need a transplant within that 6-month period of time if they were able to remain sober. But what we've learned is that the survival rate for people with alcohol-associated hepatitis is really low. And it's especially difficult and disturbing in these young patients, many of them with young families. So the 6-month survival rate, according to the Matherin paper, and the Matherin paper, as I said, was really this landmark case. It was a Belgian and French collaborative study, found that only 23% of people were alive if they didn't get a transplant within 6 months, as opposed to those who did get transplanted, who had upwards of 77% survival. Their drinking rates were considered to be pretty low. With 2 years of follow-up, only 3 out of those 26 patients went back to any drinking, which amounted to about 11%. A more recent study called the Accelerate study, which basically refers to the alcohol-associated hepatitis study that was published by Lee in Gastroenterology in 2018, consisted of data from 12 sites. The N was 141 patients who were transplanted. This study was retrospective and there is no control group in it. But they found that any drinking took place in about 25% of the population went back to some drinking at 1 year. And by 3 years, it was as much as 34%. And this is the cumulative probability. But sustained or binge drinking occurred in 10% of that population at year 1 and 17% at year 3. Again, cumulative probability. But what's really striking to me was that of those 40 patients with any drinking at all, 33 of them, or 82%, reported binge or frequent drinking at some point. So how do we make the decision? How do we select these patients for liver transplant if they have this disorder? And very few, if any of them, have been to an AA meeting or had any alcohol treatment. They really haven't had any time to think about what life is like to be sober. And we know that if they don't get transplanted within this short period of time, their risk of dying is very high. So that's where we come in. The psychiatrists, psychologists, social workers, we all play a key role in the decision to transplant these patients. And in my experience, this has probably been the most controversial and maybe stressful era for those of us who are on the front lines working with these patients and helping to make these decisions. There are really 2 primary options for the process of decision-making that are being used now in the United States and other parts of the world as well. One is to use the Matherin criteria, but it's important to remember that of all the patients that were selected and transplanted, only 1 in 10 made the cut, 10%. And the reason for that, again, is this had to be the first time that they knew that alcohol had affected their liver adversely, so the first liver decompensating event. They could have had no psychiatric or drug history. They had to have close, sober family supports. Patients and family had to agree to a lifetime of abstinence. And all the providers on the team had to agree that this was the thing to do. And that went from the transplant surgeons, nurses, coordinators, financial people, pretty much absolutely everybody on the team had to be unanimous or that patient would not be selected. The other approach is to use a flexible approach, which is really case by case. In regards to that, you really want to, it's helpful to know what the predictors of post-transplant drinking are, even though we don't have too much data yet on what the predictors are for patients with alcohol-associated hepatitis. We have many years of data describing, predictors for people with alcohol-related liver disease and cirrhosis. So in a meta-analysis by Mary Amanda Du et al., she identified multiple failed rehabs, less than 6 months of abstinence, limited social support, and family history of an alcohol use disorder as predictors of post-transplant drinking. I want to stress, though, that, and she agrees with this, that 6 months of abstinence, if you're looking at it as a dichotomous variable, meaning you either do or you don't have it, and based on that, you get chosen for transplant or not, you'll be wrong like 40% of the time. Those patients, those 40% of patients who were told they couldn't have a transplant would never have gone back to drinking, we've learned. So 6 months of abstinence is not a strong predictor, although insurance companies have really taken this on and made it almost a law or a rule that this be adhered to in order for them to support and pay for a transplant. They're beginning to they are looking at that differently now in light of this transplanting alcohol-associated hepatitis patients. Predictors of post-transplant drinking with harm to the liver is really something that I think is a more important question, because a number of our patients will go back to some drinking, and a lot of them will stop either on their own or they'll come in and get help. But the ones who really run into trouble have had prior relapse, having gone to a treatment program, have failed to engage in treatment for an alcohol use disorder despite being required to do so by a transplant team or by their doctors, whether they be primary care doctors or GI docs, and ongoing alcohol consumption despite awareness of their alcoholic liver disease. That paper was published in 2020 by our group, and Sasha Deutschlink was the primary author on that. The Accelerate AH study showed that predictors of sustained post-transplant drinking were younger age, patients of younger age, and those who drank more than 10 drinks per day. You would assume then that those people who are drinking at that level may have more of a genetic predisposition to their alcohol use disorder, starting to drink earlier, heavier, and therefore more difficulty with stopping at some point. But really, any post-transplant drinking in this population is associated with twice the rate of graft rejection and 3 times the rate of cirrhosis after transplant. So our role in evaluating these patients is twofold. One is for the multidisciplinary transplant team to assist with the decision to transplant. So we're one voice on the team. We're asked to assess the risk factors for people who may or may not go back to alcohol, drug, or nicotine use. We are also asked to look into whether or not patients will remain adherent to post-transplant medications and follow-up visits, and to work on a feasible behavioral health intervention to mitigate the risk of these problems, especially post-transplant substance use. For the patient, it's critical that you explain the purpose of the evaluation. I tell all of my patients, this is different than a standard psychiatric evaluation, although I will do, a thorough and full evaluation for psychiatric illnesses. The purpose of this is not for me to be the decider and say you will or you won't be transplanted based on this evaluation, but to see if I can come up with a plan or a path to transplant wherever possible. It's very important that patients and their families know that what we talk about is shared with the team, and that, again, not like a typical psychiatric evaluation where everything is held confidential. The components of the psych eval for those transplant candidates. Number one, you want to assess the physical condition of the patient. And as a psychiatrist, that's very important. So when you come in and you meet the patient for the first time, it's important to ask them, how are they doing today physically? Because you may find that they're actually doing very poorly and they can't actually conduct an interview. Some of them may be suffering from severe nausea. Some of them may be about to be in the process of bleeding. Others are severely encephalopathic and they can't understand the process of the interview. And therefore, you also want to assess the mental status of the patient kind of early. I explain that to my patients. I tell them that, it's important for me to get a sense of how clear they are. I ask them if they're feeling clear and if their thoughts seem organized to them, or whether or not they feel a bit jumbled up. And it seems to me that the majority of them have insight. They know that they're not thinking clearly, and they'll tell you that. If they are thinking reasonably clearly, I can conduct a standard psychiatric interview. And I like to use a lot of motivational interviewing strategies to address substance abuse in this patient. You can imagine how they feel coming into the hospital, having drunk themselves nearly to death and facing all of these physicians and nurses and therapists and having to admit to them, what their problems are, and needing to be honest, or hopefully to be honest, in order for us to figure out the best way to help them. But in many cases, you can't really even blame them for not being quite so honest. Their life is on the line. So I start by asking permission to discuss alcohol and drug use. Would it be okay with you if we talked about alcohol use? Almost all of them always say yes, it's fine. If they don't, that's information, that's data. You then get to ask them, well, what gets in the way of that? What are you worried will happen if I do ask you those questions? And then I usually get into, what did the alcohol do for you? What did you like about it? What didn't you like about it? Oftentimes patients will tell me that, when they used alcohol, it was the only way they could get to sleep, or it was the only way that they could feel calmer in social situations. Or in a couple of cases, patients with severe ADHD used it to control those symptoms. But by asking that question, you can sometimes get an underlying psychiatric diagnosis for which the alcohol was being used to self-medicate. Often you have to get into how their social life is structured and what support systems do they have. Does everyone they know and everyone they live with drink heavily? Do they only go to bars? Do they drink alone? Do they have healthy substitute activities once they've become sober? This has been found in earlier studies to be an important component of doing well. And it makes sense. If you're taking something away from somebody, what are you putting in its place to allow them to feel good about themselves and to take up time? Because as countless patients have told me, one of the main reasons they do go back to drinking after transplant is boredom. So you really want to focus in on that if you can. What motivates them to stay sober? Do they have children? Are they worried about their families? Do they feel as though their health is worth it? A lot of our patients with alcohol use disorders feel kind of guilty and ashamed about the position they're in. And they'll tell me, I don't really know if I need this or if I deserve this. There are other people who deserve it more than I do. What triggers them? What is it that makes them crave if they crave? And you also, at that point, get an opportunity to talk to them about whether or not anti-craving medications might make sense for them. At this point, it seems more than reasonable to get into the quantity and the frequency of the alcohol use. I've found that if you ask those questions up front, patients tend to become more resistant. And by asking them more about what happens in their life and in their families, you build trust, you build rapport, and then it seems as though their likelihood of being more honest and open about the quantity and frequency of their alcohol use becomes more reliable. Perhaps the most important thing is collateral information. The people who know them best, their GI doctors, their primary care doctors, their counselors, their parole officers, people who know them well, who can tell you, yeah, I think this person will be a good steward of this liver, or actually they've been seeing me for years and I've been telling them for years they have to stop drinking and get help and take medicines, and they just don't listen. They never come in for appointments. They don't have a reliable support system. This information needs to be gotten from collateral information or from collateral sources, sometimes for accuracy. So then what? Let's say you do transplant them. You have to offer behavioral health interventions, especially since so few of them have ever had them. There isn't much evidence-based information out there about what alcohol use disorder treatment to guide the field, although there are plenty of alcohol use disorder treatments out there that we know are effective. We think that right now the setting is important. There are studies in Europe and there are programs here in the United States, especially University of Michigan, where they have found that co-locating a transplant clinic with co-locating the psychiatrists and the addiction program within the transplant clinic, or by treating them with telepsychiatry, may be more effective and useful for them, especially in large transplant centers where so many patients have to travel a great distance to get here, and that becomes a barrier. Various talk therapies. Motivational enhancement therapy has shown to be somewhat effective in some of the earlier studies with this population. Doing something called symptom-triggered intervention can be useful. And that's something that we're studying at our service here. And it's a combination of cognitive behavioral therapy, supportive therapy, mindfulness, and MET. It's done all by telepsychiatry. Cell phone text messaging has been shown to be acceptable to patients, and they seem to like it and respond well to it. And this could be used for relapse prevention. One small study showed that. And of course, 12-step and 12-step facilitation is one of the most ubiquitous forms of support available. But I've found that a lot of our patients feel like they don't fit and they don't want to go to AA. And when they do go to AA, they feel like they don't belong there. People don't understand them or how they got there. And so what we did here at Penn was we started our own liver transplant group, recovery group that's specifically for these younger alcohol-associated hepatitis patients. And I have to tell you, it's been incredibly successful. Patients seem very happy. They look forward to going. They stay in touch with each other after the group is over. And I have not seen that for AA in the community ever. Pharmacotherapy is critical. You do want to make sure that there's appropriate treatment for any kind of coexisting psychiatric disorders. But I've been offering a lot of my patients naltrexone and Vivitrol, especially Vivitrol, which is the monthly injection of naltrexone that provides for patients an opportunity, I think, to cut into their craving and decrease that pull that they have. And also, if they do slip or relapse, it tends to keep them from losing control. It doesn't work for everybody, but it's worth offering it to those patients as an extra measure of support, given the severity of their alcohol use disorder. So let's see. Now we're going to be switching gears a little bit. This is my transition slide. And what I'm showing you here is, we're going to be talking about methamphetamine and cocaine use disorders in this section of the talk. This is a PET scan of methamphetamine versus cocaine concentration in the brains of users. And on the left-hand side of the screen is methamphetamine, primarily the yellow-looking brains, as opposed to cocaine on the right-hand side of the screen, which are primarily blue-colored. And what the red in the brains represents is the highest concentration of the drug that we're talking about. So if you look at the left-hand side for amphetamine, you see that there's really diffuse binding of amphetamine all over the brain. And if you compare that to cocaine, it's primarily localized in the striatum or the reward center of the brain, and not in all the other areas of the brain. And that's one of the theories behind why it is that methamphetamine has so much toxicity and lasts so much longer in these patients. The half-life of it is one thing, but it tends to actually act on the brain for much longer than cocaine does. Scope of the problem is, for cocaine use anyway, about 2.2 million regular users, with about 1 million of those patients having a cocaine use disorder in the past year. Methamphetamine, as I alluded to, is more potent, much more longer acting than amphetamines or cocaine. And in the United States, the estimate is about 353-ish thousand regular users. The focus of treatment on cocaine use disorders is what we're going to be doing today, because meta-analyses have really shown that of all the studies on pharmacotherapy of amphetamines and methamphetamines, and there are 43 such studies, really found no convincing results, primarily because the completion rates of those studies were low and the studies were underpowered. The psychosocial treatments that have been evaluated for the treatment of cocaine use disorders, and by extension to methamphetamine, have been varied. There's cognitive behavioral therapy, which has been shown to be somewhat beneficial for relapse prevention and avoiding craving in the population, and intensive outpatient therapy, which shows some benefit in reduction in use, but a very high dropout. But the most effective is actually voucher-based reinforcement therapy. And what this does basically is pay people, if you will, for clean urines. And you don't pay them with cash or money, you pay them with vouchers to exchange for things like going to the movies, going to dinner, getting a pair of sneakers, that kind of thing. And this has been shown to be the most effective tool for promoting abstinence of all the psychosocial therapies. Pharmacotherapy for cocaine use disorders has been a bugaboo for 40 years. They've studied well over 60 different medications for cocaine use, and they've not found the silver bullet yet. They looked, however, at a combination of drugs recently that seems to be showing some promise. They used dopamine agonists, and the purpose of that was to exert similar effects as the drug, cocaine, but not as abusable, in the same way that you might provide methadone or Suboxone to patients who are recovering from opiate addiction. And these are drugs that enter the brain more slowly and have a longer duration of action, and that if you can use partial agonists, that's more helpful to these patients with less side effects. For example, long-acting dextroamphetamine or long-acting mixed amphetamine salts. You also want to do something to help the GABAergic or glutamatergic system using medications that will sort of lessen the blow of the effect of ongoing amphetamine or cocaine use. So cocaine enhances dopaminergic reward system, downregulates. And the other thing is, if you activate GABA activity, which will decrease the activity of this dopamine reward system, thereby reducing euphoria and craving. So these two things you want to affect. And by blocking NMDA activity, that reduces cocaine craving and prevents relapse. And so that drug has been found to be topiramate. That seems to be effective. So recent study that's in press, it's not actually been published yet, looked at a randomized clinical trial for extended release mixed amphetamine salts and Topamax for cocaine dependence in frequent users. This is a publication that's going to be coming out in Drug and Alcohol Dependence by Levin. 127 patients, duration of the study was 12 weeks. Patients received either mixed amphetamine salts up to a maximum of 60 milligrams a day, plus Topamax to a maximum of 100 milligrams twice a day, compared to placebo. So this is a controlled, randomized controlled trial. Primary outcomes were 3 consecutive weeks of sustained abstinence measured by urine toxicology and self-report. And the results showed that for those patients who received the active treatment, they had about 14% of them were able to achieve 3 weeks of abstinence, which doesn't sound like a whole heck of a lot. But in this population, actually it is significant, as opposed to the placebo group, for which 0% were able to put together 3 weeks of abstinence. It does show you the importance of targeting neurotransmitter systems that are thought to be affected by long-term cocaine or amphetamine use. Caveats for the study is that 20% of the treatment groups were discontinued from medication because of conservative cardiac safety parameters, primarily the issues with the amphetamine salts. And it was not really possible to say which medication was driving the improvement unless we move on to a 4-arm design, which would then be like placebo versus Topamax, placebo versus mixed amphetamine salts, and then Topamax versus mixed amphetamine salts. That would be the only way to kind of tease that out. So we are now at the conclusion of this fairly rapid talk and updates. And we'll start with the liver transplant alcohol-associated hepatitis and short sobriety story. We know it's a controversial process. There's a lot of complicated decision-making that's required of us as psychiatrists in the field. We know that patients are younger and we're seeing more females, but it does look like patient and graft survival is about as good as in non-alcohol-associated hepatitis liver recipients. The role of the psychiatrist and the conduct of the psychiatric interview is really to assist the team with decision-making to list and to assist the patient by developing a plan of care that can help keep them sober and psychiatrically stable after a transplant. And right now, it seems as though the best recommendations are try to provide co-located treatment. So put the psychiatrists and put the addiction treatment personnel in the liver transplant clinic, use anti-craving meds liberally, provide really good psychosocial support and close follow-up. In terms of amphetamine and cocaine use disorders, this is a difficult to treat population. We've been trying to figure this out for decades. And it looks like the most effective psychotherapy is voucher-based reinforcement therapy. And the most effective and promising medication is the combination of extended release mixed amphetamine salts with topiramate. And this ends my talk. Thanks so much for your attention.
Welcome to this year's updates of CL Psychiatry, the discussion of neuropsychiatric disorders. This year, we will be reviewing the neuropsychiatric symptoms that result after both stroke and traumatic brain injury. I have one disclosure, which is that I have been a consultant for Avenir Pharmaceuticals, but this relationship is not relevant to this presentation. So by the end of this course, we hope that all the participants will be able to recognize the prevalence, risk factors, and correlates of neuropsychiatric complications after stroke. We would hope that you can identify treatments that are used to manage the very common neuropsychiatric sequelae after stroke, which include depression, apathy, and emotional lability. We will hope that you would identify the most common neuropsychiatric symptoms after traumatic brain injury, as well as identifying the treatments to manage the cognitive symptoms, depression, and post-concussive symptoms that may occur after traumatic brain injury or TBI. So let's start off by talking about stroke and what are some of the common neuropsychiatric sequelae that CL psychiatrists are bound to encounter in their clinical experiences on the services. The first thing to understand is that stroke is actually the 5th leading cause of death in the United States. It has a very severe global burden of disease, and about 85% of strokes that occur are ischemic. The prevalence range has sort of varied in the literature over the past several years, but the consensus between 2009 and 2012 was that there was a prevalence of about 2.6 in individuals over 20 years of age. And about 17.8% of those who were 45 years or older had experienced some kind of stroke-like symptoms. For example, weakness, hemiparesis, often associated with transient ischemic attacks. And interestingly, because of the innovations and the advancements in rehabilitation services, pharmacologic treatments, and prevention strategies, stroke incidence and mortality have both decreased over the past 30 years. It's important to think about the disparities in stroke, so we can kind of divide them up into sex and race that we commonly see from a population standpoint. Strokes are more common in men than in women when we're looking at young and middle-aged populations. Women have a tendency to have a higher lifetime risk of stroke than men. So essentially 20 to 21% versus 14 to 17% in women. Women technically tend to have poorer functional outcomes over time as well. So if you look at a lot of the studies that have followed the trajectories of women who suffered ischemic strokes or hemorrhagic strokes and follow them a year out, up to 5 years out, generally women tend to do much more poorly in terms of functional recovery. When we look at race, we see that stroke is much more prevalent in Blacks versus white patient populations. And Mexican Americans are also seen to have a higher stroke incidence in younger age groups and tend to have strokes and deaths from strokes at younger ages. You can see here in the diagram, as we go up in age, the prevalence can continue to increase, more with women and men than men. It's also important to think as a CL psychiatrist when we're seeing patients is what are some of the risk factors? What are we looking for? Who's likely to develop a stroke? And what do we want to be talking to patients about in terms of lifetime changes? So there's modifiable and non-modifiable risk factors. What's been established in the literature, and it's well known, is that modifiable risk factors are things like hypertension, hyperlipidemia, diabetes, tobacco use, and oftentimes antithrombotic therapy could be it's a risk-benefit conversation if this patient is likely to have a hemorrhagic event happen. We want to be thinking about that. Non-modifiable risk factors that have been established in the literature include age. The older ages are much more likely, but as we've just discussed, younger ages in certain ethnic populations are also at risk. Sex, race, and recent studies have looked at specific genetic polymorphisms, more specifically in the SERT transporter gene, which has been associated with a non-modifiable risk factor for strokes. There are several types of strokes, but the common ones that is important to think about are ischemic, in which that there is vascular occlusion to a particular area due to poor vascular supply, hemorrhagic strokes, which essentially is a bleed, and transient ischemic attacks, which often happen in the lacunar infarct, which are in the lacunar arteries of the brain and the basal ganglia, and very important because they can be very subtle signs that appear almost immediately. Let's move on now to talking about what are some of the neuropsychiatric symptoms that can occur after stroke. Well, this is important because there are several things that can happen, both from a psychiatric standpoint and a neurological standpoint. But oftentimes when we, as the CO psychiatrists, are called to assess patients, it's because of some kind of behavioral change, affective change, and often cognitive change. So a lot of the literature in the last decade and a half has really looked at the spectrum of neuropsychiatric consequences after stroke. But what we're going to focus on today is what a lot of the studies have sort of presented and what we have a lot of data on. That's not to say that other manifestations of neuropsychiatric symptoms are not important, but just that there are certain areas that have a little bit more robust literature than others. The more common things that we encounter with patients who have suffered a stroke are depression, apathy, anosognosia, and fatigue. So these are common things that patients who specifically come into our clinic, for example, the neuropsychiatry clinic, and say they have these types of issues, or family members will bring them in and say they have these types of problems. And then cognitive decline is something that's very important to not overlook because it can also be comorbid with a lot of the other neuropsychiatric consequences. We also can see, depending on the location of the lesion and where the stroke happened, personality changes, and emotional lability, which we will talk about a little bit. And then finally, mania and psychosis can also occur. Not as common as the other ones and somewhat more rare, but still something to be on the lookout for. So let's go over post-stroke depression. Firstly, the prevalence in the literature is a wide range, but a lot of this is because there are heterogeneous populations. They've looked at people that have studied post-stroke depression, have looked at samples that had subjects that had depression before the stroke. So there is a wide range, anywhere from 18 to 33%. But what's important to note is that about 25.4% of those who suffer depression after stroke do so or develop these symptoms within 2 years of the event. So that's an important thing to be looking at from a prevention standpoint. And we want to be thinking about early screening and early intervention when patients have strokes immediately right when they're admitted to the hospital. As discussed with general stroke risk factors, similar patterns exist with post-stroke depression. So female sex is one. Women have a tendency to have a higher risk of developing depression after stroke. Those who have a history of psychiatric illness, so pre-morbid or pre-stroke psychiatric history, specifically depression, can predispose people to having depression after stroke. Large or multiple strokes. So oftentimes when we see patients who have had multiple TIAs, some ischemic attacks, throughout the course of a 10-year span, these are people who are more likely to develop depression after having a stroke. And then stroke occurrence within the past year. So if someone ended up having a stroke, in the last 6 months, they're going to be at higher risk of developing depression in that acute period than somebody who had a stroke 5 years ago and hadn't had any psychiatric symptoms and are now presenting with such. And what's been very well established in a lot of the literature that's been looked at with Bob Robinson and several of the other experts in this field is that poor social support prior to the stroke really portends poor outcomes. And these are people who are much more likely to develop depression after stroke. Several correlates have also been studied. So one of the things is the severity of impairment in activities of daily living. So people who have strokes, and of course, the more severe the stroke, the more severe impairment, but ADLs and IADLs have a high tendency to be, poor ADLs and poor IADLs have a high tendency to be correlated with post-stroke depression. It's also been very well established in the neuropsychiatry literature that strokes in the frontal and anterior areas, specifically left lesions more than right, are more likely to predispose people or be correlated with depression after stroke, as well as in the basal ganglia. And more recently, several genes have been looked at, but the HTR3D and the NeuroG3 genes have also been implicated in the development of post-stroke depression. Of course, when we evaluate a patient and we are trying to assess what is the phenomena that we're seeing, what are sort of the syndromal aspects of the disease that we're seeing, we also have to take into consideration comorbidities. So anxiety, fatigue, sleep disturbance, and apathy are also comorbid presentations that you may find in people who have post-stroke depression. And we'll talk about each of these a little bit separately in a few minutes. So the pathophysiology of post-stroke depression is an evolving idea and an evolving, growing concept in the literature. What is known, and this is a paper that represents the study, sort of a review of the advancements in the last year of what we know about post-stroke depression. And essentially the idea is that there is a significant, after injury or after the actual insult of the stroke on the brain tissue, there is an increase in cytokine activity. We see elevations in interleukin-6 and interleukin-1 beta, as well as CRP and glutamate. So they all immediately rise and have a direct effect on the HPA axis, specifically inducing or enhancing HPA axis activity. That in turn increases cortisol, which can then lead to the cascade of lots of the symptomatology that happens. It's also been found that BDNF, or brain-derived neurotrophic factor, also tends to be low. So this plays a role in the entire pathway of post-stroke depression. So you can sort of see that the trauma occurs, trauma being the stroke, inflammation ensues, and then there's a lot of neuronal changes that occur with these particular factors that result in the depressive symptoms that we see. So how do we treat post-stroke depression? This is a tricky scenario because patients who have developed stroke oftentimes are those who are also suffering from other comorbidities that are medical comorbidities with high risks to with high mortality risks as well. So it's important when we're selecting agents to know what's been studied, the safety and efficacy of these agents, and what we know now about sort of advancements in more novel approaches. So early studies looked at antidepressants, and it's kind of well known that TCAs were much better than placebos, but we've learned over time that TCAs, particularly in elderly patients, can be much more problematic and come with a higher side effect burden. So more recent studies have looked at SSRIs, specifically escitalopram and paroxetine, which have been shown to be better than placebo in managing depression after stroke. In terms of the SNRI class, duloxetine has been one that's been shown to be effective. In the early studies, as I mentioned, TCAs were very well established as being more effective than placebo, however, having more side effects. And the two agents specifically notable to do these, to improve symptoms was nortriptyline and imipramine. In recent years, neuromodulation has come up as one of the more novel and innovative ideas in terms of treating patients who are refractory or don't respond as commonly or as well to pharmacologic interventions. So RTMS has a handful of studies that have been done with robust, with mixed evidence and not such robust findings that it's much better than placebo. But for the most part, the studies that have been done just show that RTMS does improve depressive symptoms compared to placebo. In terms of transcranial direct current stimulation, about 3 out of 4 studies that have been done in the last couple of years have shown that it is better than placebo in terms of treating depression after stroke. And finally, ECT has extremely limited studies, and we see this across the board with many neuropsychiatric disorders and ECT trials, is that there are very limited findings, primarily because of the side effect profile and other complications that might ensue. Psychotherapy has been widely studied as well, and it's been found that CBT is effective either alone or in combination with antidepressants. It's important to keep in mind that patients who have a stroke and have suffered some kind of a cognitive deficit we need to be aware that the CBT that we offer has to be modified to their ability to do some kind of a cognitive intervention. Care management, psychoeducation, behavioral activation, and family support, these are sort of what have been considered sort of in the literature as ecosystem therapies, really looking at the larger picture of how we can support the patient with all of these resources while helping their families and helping them improve. And finally, stroke focused intervention. So it's very important to kind of look at the global picture, stepping out of the psychiatric realm and looking at the global picture of the patient's rehabilitation and prognosis from a functional recovery standpoint. So getting to the bottom of etiologic investigations of the stroke, really promoting independence and quality of life extremely early on. So trying to get them to do things for themselves while they're in the hospital, while they're on the neurosurgical floors or neuro floors in the wards. And again, giving them psychoeducation and education about preventing new strokes from happening. And finally, there is robust evidence to show that specific types of rehabilitation, particularly cognitive rehabilitation, physical therapy, and occupational therapy, are very key early on. It's established that neuroplasticity can happen very early on after injury, and the sooner that these types of interventions are implemented, the better the prognosis is for the patient. Now let's move on to post-stroke apathy. This is one that can kind of get confusing and blended in with depression, but they truly are distinct and separate syndromes. So apathy is this sort of phenomenon or presentation of a patient who, and the way that I like to describe it is it's the patient that doesn't care, but they don't care that they don't care. So in other words, there's anhedonic sort of presentation, there's amotivation, but there's truly a lack of affect and a lack of dysphoric mood. And that's the thing that distinguishes apathy from the anhedonia that we see in depression. Now, apathy after stroke is very, very prevalent, and we see it in about 20 to 25% of people, but is extremely debilitating, and it can impair the patient's speed to which they recover and quality of their recovery. So some of the risk factors for those that develop post-stroke apathy are things like older age, higher pre-stroke functioning. So those who were much higher functioning before the stroke and then suddenly become debilitated because of the stroke tend to develop apathy more quickly, and more severe cognitive impairment. And we've seen this. Those with MCI or mild cognitive impairment after stroke really don't have as much of a problem with apathetic presentations as those who do not. A lot of correlates have been looked at, and we've seen that progressive functional decline really, again, predisposes the patient to more apathy, particularly if they were much more functional before the stroke. And then specific disruption of neural networks, in particular, the anterior cingulate gyrus, the dorsolateral prefrontal cortex, dorsal medial prefrontal cortex, the frontal pole, and the ventral caudate nucleus. In terms of comorbidities, we do see depression as comorbid. And again, two distinct syndromes, apathy and depression as distinct syndromes, but often can be comorbid, as well as post-stroke fatigue, which we'll also talk about. How do we treat post-stroke apathy? So this is a challenge because these are patients that we find on our services or even in our clinics that really, really don't have the desire and motivation to get up and do things to get better. And that does really delay them in their recovery. And so it is important to think about pharmacologic agents early on, particularly things that can, quote unquote, wake the patient up. For example, dopamine agonists. Stimulants are also very useful and have been studied in post-stroke apathy. And acetylcholinesterase inhibitors have mixed evidence, but what has been found is that donepezil is more effective than galantamine. And finally, nifuracetam is something that's been looked at, although doesn't have too much robust evidence in terms of how it can help with apathy. So the main go-tos usually are dopamine agonists, stimulants. Really on services and in clinical settings, we often jump to giving amantadine or some kind of methylphenidate at times can be very helpful. Psychotherapy is important, and again, kind of going back to that ecosystem type of therapy of care management, psychoeducation, and family support. And again, stroke-focused interventions, just like with post-stroke depression, are very important. So looking at the etiologic investigation of the stroke, promoting independence and quality of life, and preventing new strokes from occurring. Early rehab, very important, and particularly PTOT, very helpful when you're doing PTOT in conjunction with giving stimulants, because that can help the patient get motivated and get more sort of desire to actually go forth and engage in the rehabilitation activities. Post-stroke cognitive decline, this is an important thing to think about as well, because again, it's sort of par for the course, and is included in a lot of what we see with the other psychiatric comorbidities, with a prevalence of about 25 to 30%. It's also important to know that stroke itself is the second most common cause of an acquired cognitive decline. So when we think about patients who have had an acquired brain injury, usually stroke is one of the second most common reasons for that to happen in terms of cognitive decline. And usually comorbid with things like depression, anxiety. And a lot of literature recently has looked at the connection between post-stroke cognitive decline and vascular dementia. And there are higher correlates of those who've had more severe vascular events to develop more stepwise cognitive decline that we do see with vascular types of dementia. In terms of neuroimaging determinants of dementia after stroke, what's been looked at, particularly in those of ages 60 to 80, is that silent brain infarcts, white matter changes, lacunar infarcts, and medial temporal lobe atrophy have been associated with more of a disease progression towards dementia after stroke than just mild cognitive impairment. The treatments include things like aerobic exercise, getting the patient moving early, mental activity, and social engagement. And in a study done by Kim et al. In 2020, in patients with significant cognitive decline within the first year after stroke, acetylcholinesterase inhibitor showed an increase in MMSE scores after 24 weeks. Post-stroke fatigue is also something that's very common, with a prevalence range of about 25% to 85%, and really affects about 50 people after stroke. Comorbidities include things like depression. People can get very anxious, poor quality of life, pain, apathy, low limb heaviness, and also low thyroid. So we often check with any type of acquired brain injury a pituitary panel. We want to make sure that we're getting all aspects of hormonal disturbances that can happen after pituitary damage with any kind of a brain injury. And we often hear patients talking about that they have this kind of lull, even though they got 8 or 9 hours of sleep at night, they're waking up the next day and they just are so tired, they feel like a train ran over them. And throughout the day, they're very, very sluggish. The correlates are really stroke severity. So the more severe the stroke, the more likely they are to be fatigued. Medication use and polypharmacy. So oftentimes when they're getting several medications that overlap, this can be a problem. And then genetic polymorphisms is also something to think about as associated with fatigue. And the treatments are stimulants as well as dopamine agonists. Again, just like with apathy, trying to wake the patient up with more dopaminergic load inside. Post-stroke anosognosia is basically a lack of awareness of the underestimation of a specific deficit that they may have in sensory, perceptual, motor, affective, or cognitive functioning owing to a brain lesion. It's got a prevalence of about 10%, and it's associated with damage to right hemisphere lesions involving cortical areas, like the insular temporal areas and parietal lobes, as well as subcortical structures, like the thalamus and basal ganglia. And the clinical correlates are really that we see patients have neglect, cognitive deficits, previous strokes, and that they're older. But it's important to recognize that they're not aware and they're really underestimating these types of deficits that they have. Post-stroke emotional lability, we see a lot of pathological crying. The key thing here is that there's provocation to non-emotive or incongruous stimuli. So a perfect example is a patient is watching a commercial of a chewing gum and out of nowhere starts crying. There's nothing to sort of evoke that type of response. Whereas emotional lability and pseudobulbar affect often have some kind of provoked emotive stimuli. The prevalence is about 17% of survivors in the first month and about 20% between 1 and 6 months. And the treatment is typically SSRIs, so citalopram, fluoxetine, and sertraline have been the most studied to manage emotional lability, and TCAs as well. And more recently, we've looked at dextromethorphan, and people have looked at dextromethorphan and quinidine, or Nuedexta. So finally, the summary of this is that ischemic strokes are the most common. Depression and apathy are the most common neuropsychiatric complications after stroke. SSRIs and TCAs have the most evidence of post-stroke depression and emotional lability. Stimulants and dopamine agonists have the most evidence for post-stroke apathy, and early physical rehabilitation portends better outcomes. Now let's move on to talking about neuropsychiatric symptoms after traumatic brain injury, or TBI. So it's important to define what TBI actually is. And really, the consensus amongst various classification systems is that you have to have at least one of the following: a period of loss of consciousness, altered mental status, or any loss of memory for events. You may or may not have neurological deficits or intracranial lesions. And the extent and duration to which these symptoms happen is really what defines TBI severity. TBI is a big public health problem. At least 30.6 million TBIs occur annually. 2.8 million TBI-related ED visits happen in the hospitals in the United States annually. About 3.2 to 5.3 million people live with some kind of a TBI-related disability. Over $6 billion, it's a very expensive disease, in annual direct and indirect medical costs occur because of TBI. About 43% of those hospitalized for TBI subsequently develop functional or psychological sequelae. And it is the leading cause of death and disability in people younger than 45. So when you come into the ER and you're in the trauma bay, very likely it's going to have been, and it's a person younger than 45, oftentimes TBI is the result of their death. Several causes that can cause TBI. So falls is the most common that we see here in the left-hand corner. Then we have motor vehicle accidents, oftentimes in urban cities, assault. And more recently, we're hearing about sports concussions and sports-related hits to the head that can also be a result of TBI. Why is it important for psychiatrists to think about this? Well, it's considered the triple threat. You see the TBI, we have psychiatric problems that we may combine either the patient had before or after. And combined together, we see a lot of disability, both in occupational activities, social integration, workforce participation, as well as how they do their activities of daily living. This is probably one of the most important things to take away from this particular section, which is that what happens to a patient after the TBI depends on what happened before the injury, at the time of injury, and after the injury. That really depends on how well they're going to do. And you can look at the neuropsychiatric problems in 4 big buckets: emotional, cognitive, behavioral, and physical, and really think about the patient as they go along the trajectory of the year after their injury. Specific areas of the brain are most vulnerable to damage, and depending on where they were injured or where the injury is, it is important to think about the symptoms associated. So the ventrolateral prefrontal cortex is associated damage there with apathy. The orbital frontal prefrontal cortex damage there, we see things like agitation, disinhibition, and impulsivity. And in the dorsolateral prefrontal cortex, this is a lot of executive function, planning, switching parameters, and mental flexibility. When we look at a symptom-focused approach to the pathology, we can sort of break it up into emotional and behavioral. Emotional dyscontrol is more things like affective lability, pathological laughter and crying, which we already talked about a little bit in stroke, as well as irritability. So these are sort of the fluctuations in affect and mood that we see kind of early on. And then the problematic issues in terms of consults that we get consulted for are things like aggression and disinhibition. What's important when you look at the syndromes after TBI are that those that have TBIs are more predisposed to developing psychiatric syndromes. So major depression, which is the most common, anxiety disorders, and substance abuse. And you can see here when you compare psychiatric syndromes with those that have TBI versus the general population, the prevalence is much higher in those that have had a TBI. When we look at the syndrome-focused approach, we can kind of think of specific symptoms that we're looking at within each syndrome. Cognitive deficits, which accounts for about 5 to 60%, which include things like poor memory, poor attention, processing speed, executive dysfunction. Depression, which has a prevalence range of 13 to 53%, and this includes things like low mood, irritability, suicidal ideation. Patients with depression after TBI have a little bit more of an agitated depression than we see in patients that have idiopathic depression. Mania is not as common, but we do see some similar symptoms that we would with idiopathic mania. Anxiety has a prevalence rate of about 11 to 70%, and commonly we see sort of persistent worry and autonomic arousal. And then apathy, similar as to what we discussed in stroke, again, that's about a 10% prevalence with this lack of motivation, drive, and loss of initiative. Again, very dependent on where in the brain the damage happened. The stepwise neuropsychiatric approach to treating TBI is really doing a comprehensive psychiatric evaluation, brief neurological exam, making sure we're having a problem-focused workup, taking a look at the symptoms that are most bothersome. Is it fatigue? Is it post-concussive symptoms? Is it sleep? And go forth with a thorough workup after that. We want to use ancillary studies to help establish the diagnosis. Always using a multi-pronged formulation, not just thinking about the disease aspect, but what about their behaviors, their personality, and their life story contribute to their presentation. Using multidisciplinary treatment, sort of coordinating with neurology, audiology, PM&R, and other specialties to make sure that we're coordinating care. And usually doing consultations and referrals to make sure that even we are getting as much of a robust, widespread, casting a wide net to make sure we're getting all of the patient's physical needs met. Most importantly, management of post-TBI symptoms is multidisciplinary. So as I just mentioned, we're reaching out to all of these specialties and asking how we can collaborate and coordinate care. Most importantly, to make sure that their rehabilitation is very comprehensive and precise, and also that we're watching for polypharmacy. We want to make sure that we're very, very gingerly going up on medication doses, choosing a medication, starting low, going slow, doing a continuous trial of all meds, making sure we're avoiding polypharmacy. And what's really been established in the TBI literature is that we want to avoid benzodiazepines and first generations antipsychotics because they can impair neuronal growth, as well as anticholinergics and antihistaminics. Lots of medications have been examined in TBI, but the studies are really not as robust as we would have with idiopathic syndromes, such as idiopathic depression, et cetera. But what has been studied in terms of treatment is that sertraline and citalopram are the most studied SSRIs and antidepressants, which have been shown to be helpful in managing depression. Quetiapine and valproic acid have also been useful to manage manic symptoms, which again are rare, but can happen after TBI. Sertraline has the most robust evidence for PTSD. And for psychosis, again, we want to use medications that don't have many side effects and are not too D2, that don't have too strong of D2 antagonism. So quetiapine has been examined and can also actually protect the blood-brain barrier. Risperidone at very low doses has been also found to be helpful. For insomnia, Ramelteon and Trazodone have also been found to be helpful. In terms of apathy, just like with stroke, stimulants at doses between 5 and 40 are also helpful. For memory deficits, donepezil and cholinesterase inhibitors can be very helpful, and these we have to watch for bradycardia. For executive function deficits, dopamine agonists, amantadine is widely used, and in one study that looked at severe TBI was shown that processing speed was improved at doses between 100 and 400. And then for inattention, we can continue to use methylphenidate. Rehab is very multifactorial and multidisciplinary. We often want to think about occupational therapy, mindfulness, vocational rehabilitation, skills for social reintegration, and very importantly, anger management, because that's a huge piece of their sequelae, and talking to family members and letting them know this is what you can expect. And we always come back and we tell the patient, you know, we're not going to get you to how you were before the injury, but we can certainly get you back to what you are, better than you are now. So in summary of TBI symptoms, neuropsychiatric sequelae can develop within weeks to a month after TBI. So they can happen immediately after to months after, right after the injury. Within the first year, patients suffer loss of quality of life, poor social functioning, and difficulties with disability overall. We can use both a symptom-focused approach and a syndrome-based approach, but what's important to look at is what are we targeting and how can we do this in a multidisciplinary fashion. With pharmacologic interventions, these should involve medications that are low, avoid polypharmacy, and really try to target the acute symptoms. Always ask the patient, what's the primary issue that you're worried about right now? And psychosocial rehabilitation is key. It's important to make sure that we're getting OT, PT, and cognitive rehabilitation, as well as vocational interventions integrated very early on so that they can move forward with their prognosis much faster. And with that, I thank you.
Welcome to this year's update on cardiovascular psychiatry, high-yield clinical pearls in the age of COVID and beyond. I'm Margot Funk. I'm the Director of Cardiovascular Psychiatry at Brigham and Women's Hospital, where I'm also the Program Director of the Adult Psychiatry Residency and the Vice Chair of Education in the Department of Psychiatry. I have one disclosure, which is the provision of QTC education for Acadia Pharmaceuticals, but for a drug that is unrelated to my talk today. So over the past year, there's been much learned about the effects of the SARS-CoV-2 virus on the heart. And as CL psychiatrists frequently now encounter patients with COVID and cardiovascular comorbidity and complications, today's discussion will be focused on things that you really must know about COVID-19 and the heart. We will then transition to some pharmacology updates and implications for risk of cardiac arrhythmias. And then we'll conclude with a brief discussion about the importance of the CL psychiatrist having utmost competency with ECG interpretation. To highlight our discussion today, let's start with a real case. So this is a 32-year-old woman with a past medical history of childhood uterine rhabdomyosarcoma. She's status post chemotherapy for that as a child, but this was complicated by recurrent nephrolithiasis and pyelonephritis that ultimately led to renal failure, and she's now status post bilateral nephrectomy, currently receiving hemodialysis. Her psychiatric history is notable for generalized anxiety disorder, depression, and she's on citalopram and quetiapine. She was planned for a renal transplant from her donor father in the summer of 2021, but then she developed pneumonia-like symptoms secondary to COVID-19, and she was vaccinated. She was started on remdesivir and prednisone. However, remdesivir was stopped after 3 days due to persistent bradycardia into the 30s. And on hospital day number 5, she developed torsade de pointes, requiring shocks twice, 2 rounds of CPR, amiodarone, and then finally return of spontaneous circulation. She was then started on isoproterenol for rate control to keep her out of a bradycardic range. Citalopram and quetiapine were stopped, and her cardiac MRI was suggestive of COVID myocarditis. So this is a complex case with multiple things going on. Our patient has myocarditis due to COVID. She's on multiple QTC prolonging medications. She is bradycardic, setting her up for torsades, and she's also on hemodialysis, and so at risk of dramatic fluid and electrolyte shifts. So this might be a common type of patient that you may see on the inpatient CL service now in the age of COVID. This was her ECG 90 minutes prior to her episode of torsades, and you can see that she was quite bradycardic at the time. Her QT interval was prolonged, and she had multiple PVCs occurring at the end of repolarization, which is a typical trigger for torsade de pointes, known as an early after depolarization. So now that we've set the frame with what you might see clinically, let's jump right into the pathophysiology of COVID-19. So looking at the figure on the right, you see that infection with the SARS-CoV-2 virus is mediated by the interaction of the virus's spike protein with the angiotensin-converting enzyme 2 receptor, which is present on a variety of cells, as you can see in the figure on the left. This includes lung epithelial and alveolar cells, cardiomyocytes, vascular endothelial and smooth muscle cells, as well as cells in the GI tract, kidney, and the brain. And so binding of the spike protein of the virus to ACE2 is then followed by proteolytic cleavage of ACE2 by the transmembrane serine protease 2. This then facilitates entry of the virus into the cell, viral replication occurs, and then you have cell-to-cell transmission of SARS-CoV-2 or COVID-19. Now, ACE2 is an important counter-regulator of the renin-angiotensin-aldosterone system. And you'll recall from medical school that under physiological conditions, the renin-angiotensin-aldosterone system works as follows. So you have angiotensin-converting enzyme, which metabolizes angiotensin 1 to angiotensin 2. This leads to increased vasoconstriction. It promotes reabsorption of water and sodium from the kidneys. It promotes oxidative stress, inflammation, fibrosis, and edema, and ultimately tissue injury to the lungs and to the heart. Now, conversely, angiotensin converting enzyme 2, or ACE2, this inactivates angiotensin 1 by generating angiotensin 1 to 7, which then interacts with the G protein coupled receptor MOS. Now, this interaction lowers blood pressure through vasodilation. It protects blood vessels. It promotes excretion of water and sodium from the kidneys, and it attenuates inflammation and tissue damage. So the balance of these two systems impacts whether or not there will be tissue injury from a given stress, especially in the lungs and in the heart. So now enter infection with SARS-CoV-2, which downregulates the expression of ACE2, leading to overactivation of the renin-angiotensin system and to increased tissue injury. Now, notably, more than 7.5% of myocardial cells have positive ACE2 expression, which we think can mediate SARS-CoV-2 entry into cardiomyocytes and actually cause direct cardiotoxicity. So acute myocardial injury is a fairly common finding in patients affected with COVID-19. And an early study from Wuhan, China, of 139 hospitalized patients with COVID-19 found that cardiac injury was present in 7.2% of all patients and 22% of patients requiring ICU care. Furthermore, arrhythmias were present in 16.7% of patients, with 44.4% of patients requiring ICU care. A number of different pathophysiologic mechanisms likely contribute to the many types of cardiovascular injury that have been described in patients with COVID-19. So we've already mentioned direct cardiotoxicity from ACE2 mediated entry of the virus into the cardiac myocyte. And then inflammation, oxidative stress, cytokine storm are all thought to mediate many of these other conditions, which you can see in the figure in the slide. These include myocarditis, which is a direct inflammation of the myocardium, ischemia and myocardial infarction, which may occur from inflammation-induced plaque rupture or from the supply and demand mismatch of oxygen to the myocardium in the context of respiratory decline from the COVID virus. It can also result in heart failure, which may result from inflammation of the myocardium, but also from stress cardiomyopathy or Takotsubo syndrome, or from non-cardiac causes such as pulmonary embolism due to COVID-induced coagulopathy. Finally, there are a wide range of arrhythmias that may occur depending on the location of the damage to the heart and also due to stress-induced changes to ion channel expression, which we'll discuss a little bit more. So as exemplified in our case, as CL psychiatrists who prescribe psychotropic medications to patients with severe illness, we really need to be vigilant about the malignant ventricular tachycardia called torsade de pointes, which you can see here as classically represented by the change in amplitude of the QRS complex around the isoelectric baseline, shifting into a ventricular tachycardia, known as twisting of the points and in French, torsade de pointes. So in addition to the many forms of direct cardiac injury that we've talked about in COVID-19 patients, we also know that they are especially vulnerable to torsade de pointes. So thinking back to our risk factors for torsades in the patient who doesn't have COVID-19, we know that overall risk is mediated by the number of concurrent risk factors, which can be categorized by non-modifiable and modifiable. So our non-modifiable risk factors include female sex, advanced age, metabolizer status, congenital long QT syndrome, or a personal history of either drug-induced QTC prolongation or of structural or functional cardiac disease. And finally, or of a family history of sudden cardiac death. The modifiable risk factors can include use of one or more QTC prolonging medications, drug-drug interactions that may impair metabolism and cause drug toxicity, certainly also drug toxicity via overdose, and then severe acute illness, bradycardia, which is a big one that we pay attention to, starvation, hepatic and renal impairment, and then electrolyte derangement, and specifically hypokalemia, hypomagnesemia, and hypocalcemia. So now add on to that infection with SARS-CoV-2. So COVID-19 illness really confers a substantial risk, really due to the sheer number of risk factors, which are highlighted here in yellow. These all go along with severe COVID illness. We know that most patients with severe illness due to COVID are of advanced age. As we've discussed, they're at risk of myocardial injury due to a number of mechanisms. So now we can add a personal history of structural or functional cardiac disease. Patients with COVID-19 may be on multiple QTC prolonging medications, including chloroquine or hydroxychloroquine, azithromycin, amiodarone, or other antiarrhythmics due to cardiac injury. These medications may in turn have interactions that inhibit the metabolism of other at-risk drugs. And these patients certainly have severe acute illness and can suffer multi-organ failure that could lead to drug toxicity from impairment of hepatic and renal drug clearance. Patients who are being treated with remdesivir or receiving sedation with dexmedetomidine are increased risk of bradycardia, which, as we mentioned, is a very concerning risk factor for torsades. And certainly electrolyte disturbance may occur in the context of multi-organ dysfunction. So when we're thinking about medications that have risk of QTC prolongation, we should recall the electrophysiology of what's actually occurring in the heart. Drug-induced prolongation of repolarization, which we can also think of as acquired long QT syndrome, is primarily mediated by the slow inward rectifier potassium channel of the cardiac myocyte, known as the hERG channel. Many QTC prolonging medications directly block the hERG channel, blocking efflux of potassium from the cardiac myocyte, which you can see here in the top panel on the right. So in the middle and bottom panels, which represent ion flow during the cardiac action potential, you see an initial inward spike of sodium influx, followed by calcium influx, and these result in ventricular depolarization. Then you see potassium efflux, which results in repolarization. So when potassium efflux is slowed due to this channel blockade, that portion of the action potential is slurred outward. And you can see this with the lighter green line in the bottom panel. So then looking at the figure on the left, if you look at the top portion of this figure, this shows the cardiac myocyte action potential, first in a normal state and then with prolonged potassium efflux. And then on the bottom, you can see how the normal action potential translates onto the electrocardiogram, first on the left with a normal T wave, and then on the right, the T wave you can see is widened and distorted, leading to a prolonged QT interval. Now, it's known that during acute infection, the risk of malignant ventricular arrhythmias like torsades is increased. It's generally believed that QTC prolongation during the course of infection is almost exclusively due to the concomitant treatment with QT prolonging antimicrobials. However, direct effects of inflammatory cytokines on ventricular repolarization are now being increasingly recognized. In this study here by Lazzarini and colleagues, they hypothesized that systemic inflammation can significantly prolong the QTC during acute infections, and that this is via cytokine-mediated changes in potassium channel expression. So what they did was a 3-part study that evaluated the frequency of QTC prolongation and its association with inflammatory markers in patients with different types of acute infections. They also looked at the prevalence of acute infections in a cohort of consecutive patients with torsades de pointes. And they finally looked at the relationship between potassium channel mRNA levels in ventricles and peripheral blood mononuclear cells and their changes in patients with acute infection over time. They found that in patients with acute infection, regardless of concomitant QT prolonging antimicrobial treatments, the QTC was frequently and significantly prolonged, but then rapidly normalized in parallel with both C-reactive protein and cytokine level reduction. They also showed that in a cohort of consecutive patients with torsades at their medical center, concomitant acute infections were consistently highly prevalent at a rate of 30%, despite only a minority of these cases being treated with potentially QT prolonging antimicrobial drugs. And then finally, they looked at KCNJ2 channel expression, which encodes one of the pore-forming subunits of the inward rectifier potassium channel. And they looked at this in peripheral blood mononuclear cells, which strongly correlate to expression in cardiac ventricular tissue. And they found that inward potassium channel expression, inward rectifier potassium channel expression, was inversely associated with CRP and IL-1 changes in patients with acute infections. So altogether, this data suggests that during an acute infection, systemic inflammation can significantly prolong QTC and increase the risk of torsades by rapidly inducing reversible cytokine-mediated ventricular electrical remodeling. And although this is transitory, the changes may significantly enhance the propensity to life-threatening ventricular arrhythmias and cardiac arrest, particularly when other QT prolonging risk factors are also present. So now looking at COVID-19 specifically, this is a cohort study of 965 patients from early in the pandemic who were tested for COVID-19 and evaluated for change of QTC. The QTC here was calculated with Friedreichia at baseline, at 2 days, and at 5 days. And notably, many of these patients received empiric hydroxychloroquine and or azithromycin prior to actually receiving their PCR COVID test results, which at that point in time could take several days. And as such, many of the patients who eventually tested negative still received full treatment courses of these medications. And so this design allowed for comparison of QTC in COVID-19 positive and COVID-19 negative patients, since some patients in both groups received QTC prolonging medications for a full course. And what they found was that infection was independently associated with longer QTC intervals from baseline, and patients at higher risk were those who were 80 years or older, those who had an elevated high sensitivity troponin level, or those who had significant renal dysfunction. They also noted that 1/4 of patients with COVID-19 who did not receive hydroxychloroquine or azithromycin experienced QTC of 500 milliseconds or greater, compared to only 10% of patients without COVID-19 who didn't receive either of the medications. And so this data, in summary, suggests that increased risk of QTC prolongation with COVID-19 infection can occur even in the absence of any known QT prolonging medications like hydroxychloroquine and azithromycin. So of the medications known to prolong the QT interval, chloroquine, hydroxychloroquine, and azithromycin, like we mentioned, are the ones that have been used in the treatment of COVID-19. Chloroquine and hydroxychloroquine have long been used as anti-malarial and immunosuppressive agents for the treatment of lupus and rheumatoid arthritis. And early in the pandemic, these drugs came into use as a treatment for COVID-19, often in conjunction with azithromycin, which is a macrolide antibiotic known for its risk of QTc prolongation and torsades. Now, both chloroquine and hydroxychloroquine are known to cause QTc prolongation. And as we know, when there are multiple QTc prolonging agents used in combination, there is increased risk for torsades. So a recent meta-analysis of the effect of hydroxychloroquine with or without azithromycin on QTc prolongations in patients that were hospitalized with COVID-19 was performed. And they found 18 studies and included about 700 patients who met inclusion criteria for their analysis. The results of their study demonstrated that hydroxychloroquine alone, azithromycin alone, or the combination of the two was associated with increased number of patients that developed QTc prolongation greater than 500 during hospitalization. Now, notably, the half-life of hydroxychloroquine is very long. And so in isolation and for acute treatment is not considered highly arrhythmogenic given the short 5 to 10-day treatment course. However, when this is combined with other QTc prolonging agents, the scenario changes and risk increases. In addition to drugs that are actually blocking the inward rectifier potassium channel, drugs that cause bradycardia can cause significant risk of torsades. So remdesivir is one of these. It is an RNA polymerase inhibitor that was authorized for severe COVID-19 patients without mechanical ventilation needs. This is an important agent to keep on your radar because we know that when this causes bradycardia is a significant risk factor for these early after depolarizations to trigger torsades. The ECG that you see here demonstrates bradycardia with remdesivir, and you can see that this heart rate is quite low. There have been numerous reports of severe bradycardia due to remdesivir, and a recent study of 52 patients with COVID-19 treated with remdesivir found significant decrease in heart rate from baseline. And so as such, CL psychiatrists really must be aware of this risk if they're going to be prescribing other QTc prolonging agents alongside remdesivir. Dexmedetomidine is another one to be on the lookout for. So this is an alpha-2 adrenergic agonist that has also been used quite frequently in patients with COVID-19. It can be used as an anesthetic adjunct in intubated patients, but it can also be used for light sedation in awake, spontaneously breathing patients, either with or without non-invasive ventilation. Compared to traditional sedatives and anesthetics, dexmedetomidine really has little effect on respiration, which makes it an ideal sedative for respiratory compromised but spontaneously breathing patients. It's also been shown to carry both cytoprotective and anti-inflammatory properties. And though it's an effective agent for providing sedation without the risk of respiratory depression, it does have significant cardiovascular effects. And specifically, these are blood pressure and heart rate lowering effects. So now that we've talked about COVID-19 specific drugs that can increase the risk of torsade de pointe, either through prolongation of repolarization or bradycardia, let's briefly shift our attention to psychotropic medications that affect calcium, sodium, and potassium cardiac ion channels. The figure on the right is another schematic of the cardiac action potential, ECG correlate, and ion flow. Calcium channel blockers such as tricyclic antidepressants, lithium, benzodiazepines, clozapine, and carbamazepine have been implicated in sinus node dysfunction and atrioventricular block. Sodium channel blockers, also including tricyclic antidepressants, lithium, loxapine, carbamazepine, lamotrigine, oxcarbazepine, cocaine, and also cannabis, can unmask Brugada syndrome, which can be a cause of sudden cardiac death. They can also result in ventricular conduction delay, most often visualized as a bundle branch block and widening of the QRS complex. Finally, and probably the most familiar to CL psychiatrists, are the medications that can prolong the QTC interval and increase the risk of torsades through blockade of the inward rectifier potassium channel. And the most significant offenders here include the low potency phenothiazines, methadone, ziprasidone, iloperidone, and citalopram. So the take home from this slide is to have increased vigilance anytime you see an ion channel blocker prescribed in a patient who has COVID-19. Now let's shift gears to focus in on one of these medications, lamotrigine. In October of 2020, the FDA issued a warning on lamotrigine, warning of its proarrhythmic potential by slowing ventricular conduction, including sudden cardiac death in patients with structural heart disease and myocardial ischemia. And the FDA advised to avoid the use of lamotrigine in patients who have cardiac conduction disorders, including second or third degree heart block, ventricular arrhythmias, or cardiac disease or other abnormalities. They also added that concomitant use of other sodium channel blockers can increase the risk of proarrhythmias. Now, in response to this warning, an ad hoc task force of the International League Against Epilepsy and the American Epilepsy Society was convened to really extensively evaluate the evidence regarding cardiac risk associated with the use of lamotrigine. They emphasized that the likelihood of asymptomatic cardiac disease is low among individuals younger than 60 without cardiovascular risk factors or symptoms. And so therefore, they recommended to add no additional precautions for the initiation of lamotrigine, but recommended that a cardiologist's opinion should be considered before starting lamotrigine in people with comorbid cardiac conditions. The task force recommended that in people older than 60, an ECG should be done on lamotrigine initiation, but it shouldn't delay initiation, especially consider that there are dose-dependent effects on cardiac conduction, and lamotrigine requires a very slow titration schedule. In March then of 2021, the FDA then removed the statement to avoid use in any specific population and now recommended that healthcare professionals assess whether the potential benefits of lamotrigine outweigh the potential risk of arrhythmias for each patient. They continued, however, to recommend that lamotrigine can cause increased risk of serious life-threatening arrhythmias, and that if lamotrigine is used in combination with medicines that block sodium channels, that these cannot be considered safe until more evidence is available. So the case of lamotrigine reminds us of the importance of being able to recognize a wide QRS complex, which is characteristic of sodium channel blockade. And this is shown in this ECG here. We know that a wide QRS greater than 110 milliseconds is the electrocardiographic correlate of ventricular conduction delay, which is often due to bundle branch block, but can also be seen in ventricular pacing. This is an ECG of a patient after a tricyclic antidepressant overdose. And you'll recall that tricyclics are also sodium channel blockers. The QRS complex here is 200 milliseconds, much wider than the normal range of 80 to 100, representing sodium channel blockade. And QRS widening is what you would be looking for if performing a screening ECG prior to initiating a psychotropic sodium blocker like lamotrigine. The case of lamotrigine reminds us of the importance of being able to recognize a wide QRS complex, which is characteristic of sodium channel blockade on the ECG and is shown here in this ECG. A wide QRS greater than 110 milliseconds is the electrocardiographic correlate of ventricular conduction delay, which is often due to bundle branch block, but can also be seen in ventricular pacing. This is an ECG of a patient after a tricyclic antidepressant overdose. And you'll recall that TCAs are also sodium channel blockers. The QRS complex here is 200 milliseconds, so much wider than the normal range of 80 to 100 milliseconds, representing sodium channel blockade. QRS widening is what you would be looking for if performing a screening ECG prior to initiating a psychotropic sodium blocker like lamotrigine. So let's finally look at one more case, this time to practice QTC interpretation in the setting of a widened QRS complex. So this is the ECG of an 87-year-old man with neurocognitive disorder, coronary artery disease, whose status post a dual-chambered pacemaker for second-degree heart block, who was admitted to the medical hospital for delirium workup in the setting of worsening paranoia and agitation. His medical workup was negative, with paranoia attributed to progression of his dementia, and the paranoia resolved with the addition of olanzapine. Now, unfortunately, over a weekend when the medical coverage was being assumed by a new covering team, his olanzapine was discontinued due to, quote, QTC prolongation, based on the ECG computer interpretation, which reported the QTC Bazette as 559 milliseconds. When we zoom in on this ECG, we see a pacing spike here and a wide QRS measuring 160 milliseconds in this panel B insert. Panel C is an example of a normal QRS, which you can see is much more narrow than in panel B. Our patient's QT interval in panel B is slightly longer than two large boxes at 460 milliseconds. And when we use a linear heart rate correction like Hodges, we find that the QTC is 492. When using linear heart rate correction, and since we know that QRS is widened due to ventricular pacing in this case, we must correct for this when we calculate the QTC. So one of the best methods for this is to use the JTC instead of the QTC. The JT interval includes the ST segment and the T wave, and it's a more accurate representation of ventricular repolarization than the QT interval, which represents both ventricular depolarization and repolarization. The JT can be corrected for heart rate using the same linear correction formula used for the QTC. And the upper limit of normal JTC for men is 355 milliseconds, and for women, it's 372 milliseconds. So the JTC for this ECG is 332 milliseconds, well within normal. This case really demonstrates the importance of being able to accurately identify, measure, and calculate important intervals on the ECG, and to interpret how what you are seeing on the ECG actually correlates with the clinical scenario. In this case, because the covering team did not know how to accurately interpret the ECG, an important psychopharmacologic agent was inappropriately withheld, resulting in psychiatric decompensation. So as the expert at the interface of psychopharmacology and complex medical illness, the CL psychiatrist really must be competent with the identification, measurement, calculation, and interpretation of relevant aspects of the ECG. And they must be aware of the knowledge gap about the QT interval across medical specialties. Now, notably, a study of 902 physicians found that greater than 50% of cardiologists and 60% of non-cardiologists could not correctly calculate and commonly overestimated the QTC in healthy subjects. This is a figure from that study where the vertical bars show percentage of correct identification of either prolonged QT or normal QT among QT experts shown as QE, arrhythmia experts shown as AE, cardiologists who are notated as C, and then other specialties notated as NC. And I think perhaps the most notable difference about these data are the differences between the cardiologist and the QT expert, showing that the cardiologist scored much more closely to all other specialties. And this is perhaps not surprising, as I think many of us has had the opportunity or the experience of knowing more about the QTC than our cardiologist colleagues. This can be tricky to navigate, but it highlights that as the experts of psychopharmacology and complex medical illness, CL psychiatrists really must have a comprehensive understanding of the ECG. The American College of Cardiology and the American Heart Association recognize that physicians of any specialty may provide initial ECG interpretation in the absence of a cardiology overread. And it's really imperative for CL psychiatrists to serve as a liaison to provide nuanced education about the QTC and the ECG as it relates to prescription of psychotropic medications. And we must really remain vigilant for erroneous approaches to medication management that could needlessly result in psychiatric decompensation or delay of treatment due to inaccurate interpretation of the QTC. So for a comprehensive approach for ECG interpretation for the CL psychiatrist, I encourage you to check out the ACLP pre-conference course on QTC prolongation, torsade de pointe, and psychotropic medications with Dr. Scott Beach, Chris Solano, and myself. And this will include a live interactive portion with practice ECGs and complex clinical cases. I thank you for your attention and welcome any emails for any questions about the content presented today.
Greetings. My name is Damir Huremovic, and I'm here to provide you with the current COVID-19 updates. I have no relevant disclosure to make. The goal of this presentation is as much to provide you with the facts as it is to stimulate critical thinking and strategic thinking that will position you as leaders in your health systems, allowing you to take the leading role in advancing both the fight against COVID-19 and integrated care. Our objectives for today are to define the framework of historical, social, and medical context within which the current COVID-19 pandemic unfolded, to postulate its remaining course and identify possible consequences on global society and the practice of medicine and psychiatry, to provide overview of current knowledge on neuropsychiatric components and manifestations associated with COVID-19 and its treatment, including the indirect psychological toll associated with global mitigation measures. And then to identify and outline the areas with a prominent knowledge gap and with identify considerable situational opportunities that as areas of interest for future research in psychiatry and public mental health. Here are some of the questions that can stimulate our discussion in our presentation. Why are some of my patients or family members or even colleagues so adamantly refusing or questioning the vaccine? How come there are still large swaths of population firmly believing that COVID-19 is a hoax or at best a mild disease with its features artificially inflated by the government agencies? Is there a correlation and connection between COVID-19 and social movements such as Black Lives Matter? How will my practice and our profession change and evolve over the next several years? How can I study the interplay between infectious diseases and mental health? It is now the right time and the right opportunity. So when we look at the mental health burden imposed by pandemics, we can roughly divide them into direct and indirect. Direct are mental health burdens caused by the disease itself. And they are the domain of psychiatry and medicine and understood and managed by studying medicine and psychiatry. The indirect mental health burden is caused by our response to the pandemic, and it belongs to the domain of public health and public policy. It is best understood and managed by studying social sciences. There was, however, inadequate understanding on each side of what does it entail and how it affects our well-being. So direct effects of a pandemic were not sufficiently understood by public health officials. And then indirect mental health burden was also not adequately understood because of inadequate involvement by mental health professionals. It is not possible to start practicing psychiatry of a pandemic without understanding its psychology. Here's a quote from our book. Very few phenomena throughout human history have shaped our societies and cultures the way outbreaks of infectious diseases have. Yet, remarkably little attention has been given to these phenomena in behavioral social science and in branches of medicine that are at least in part founded in social studies. We may postulate on why there appears to be an inherent bias in studying rapid outbreaks. They may be too intense to tolerate and too short in duration to sustain systemic attention. There may be too rare of an event and too unpredictable to attract resources in Western medicine. And then there may be implicit institutional racism reflected in a lack of interest in Western medicine to study diseases that affect primarily societies and people of color, diseases and disasters that happen somewhere else. In a long succession throughout history, pandemic outbreaks have decimated societies, determined outcomes of wars, wiped out entire populations, and also paradoxically cleared the way for innovations and advances in sciences, including medicine and public health, economy, and political systems. So what does that mean for us? It means that a pandemic of this size is bound to change the course of history, and we live in the midst of one, both the pandemic and the change of course of history. Many staples of contemporary lifestyles will fall by wayside, giving rise to new forms of commerce, interaction, services, and healthcare. As mental health professionals, we are expected to provide support and reassurance through a scary and uncertain period of change to both ourselves and our loved ones, colleagues, patients, and the general public. And while doing so, we are dealing with a lot of unknowns. When dealing with a lot of unknowns, there is a rush to fill the knowledge gap. And a lot of papers, findings, and research get published without sufficient scrutiny, only to be retracted and then disappear later in the course of time. So we have to be patient and have to be understanding that it takes time to come up with evidence of high quality to help us fight what we're fighting right now. So let us start with structuring what we actually know about neuropsychiatric aspects of COVID-19. What is our baseline? Are there emotional issues associated with impending outbreak without having been directly exposed to the microbial agent itself? What are the immediate direct sequelae of acute COVID-19 for those who acquire it and survive it? What are the psychiatric aspects of losing a loved one to COVID? What are the neuropsychiatric complications of protracted or so-called long-haul COVID-19? What are the indirect consequences, emotional and psychiatric toll of measures aimed at preventing the spread of the pandemic, such as social distancing, but also delayed care or limited access to healthcare and economic hardship? So how big is this pandemic compared to some other ones? Here's a quick comparison between the last one that we had over 100 years ago and the current one. So the Spanish flu of 1918 through 1920 had about 4 waves. We are now in, depending on how you look at it, 3rd or 4th wave of COVID-19. It affected 500 million people back then, but that was about 1/3 of the global population. And COVID-19 has affected about 250 to 300 million. Global deaths were about 25 to 50 million, and we are approaching 5 million with COVID. With Spanish flu, the number of cases in the US was 30 million, which was well over 1/4 of the then current population of the US. With COVID-19, we are at about 50 million cases. The number of deaths was under 1 million in 1918 through 1920, and now in late 21, we are approaching 1 million fatalities due to COVID-19. Most susceptible were the younger ones in the case of Spanish flu, whereas COVID-19 mostly adversely affects people over the age of 65. How much does COVID-19 cost us? We really don't have an exact figure, but the estimated cost through October 2020, which was basically a year ago, was $16 trillion. And that's about under $200,000 per 4-member family. In addition to direct cost of the outbreak, one has to account for opportunity cost. What else we could have done while we were busy fighting COVID. In economic terms, this money could not have been invested elsewhere, such as economic growth. So that's the bad part. The good part is probably that we couldn't also invest this money in waging wars. In terms of healthcare, resources had to be diverted from different services to test, prevent, treat, and rehabilitate COVID-19 caseload. Global healthcare at some point was put on a global pause to tend to COVID-19, missing the opportunity to manage and treat many conditions, including mental health illness. So the last question here in terms of cost is, how much does COVID-19 and its management interfere and cost us in terms of our civil liberties? So when we look at it, we know that we're basically facing a black box of unknown variables, something that we kind of knew we didn't know. There was a research in 2004 called Redefining Readiness that suggested that the general population may not react to a public health crisis in the manner anticipated by emergency management professionals. That unanticipated behavior can complicate the management of a disaster situation and lead to higher rates of long-term mental health problems. During that exercise, in a simulated scenario, it turned out that Americans were twice more worried about smallpox vaccine than about contracting smallpox themselves. We also knew that contagion exists and has existed well over 100 years as a psychological concept. And there has been this nascent idea of emotional epidemiology as well. Public reaction is guided by the perception that there is a limited opportunity to escape, there is a high risk of being injured or killed, or that the help will only be available to the very first people who seek it. And that can kind of spread the uneasiness and anxiety that tends to surround the spread of the actual disease itself. So there are some things that we did know and some things that we didn't know, but we learned the hard ways from this pandemic. We did know that we could not anticipate and account for public behavior and attitudes in such situations. We've known it for a while and we've failed to study it better. The concept of emotional epidemiology implies the emotional outbreak that mirrors the actual outbreak of the disease. We knew that there will be a considerable vaccine hesitancy once there was one or more viable vaccines. We knew that the longer the outbreak, the bigger the chance for viral mutations. Also, the longer the outbreak, the bigger the disproportionate burden of disease on minorities and disenfranchised communities. What we did not know and learned during this outbreak was that there would also be a significant proportion of disease deniers interfering with public policies and measures to attenuate the outbreak. We did not know that segments of global and national public health systems responsible for the outbreak were not adequately prepared for it. And we did not know how easily and skillfully political and partisan agents worldwide would use COVID-19 to advance their political agenda. Let us take a look at the current COVID-19 immunization status. In the United States, it's still limited. Almost 2/3 of the population have received at least one dose, and well over 1/2 have been fully vaccinated. Globally, about less than 1/2 of the world population have received at least one dose of COVID-19, and 6.5 billion doses have been administered, with 25 million doses being administered daily. However, only 2.5% of people in low-income countries have received that one dose. What we can see is that the rate of immunization is slowing down both in the US and globally. Now that we know a little bit about how much COVID-19 has cost us so far, how much or will continue to cost us going forward? Well, because of stalled immunization process and the emergence of the Delta variant, COVID-19 will remain a thorn in our side for the foreseeable short-term future in the next 6 to 12 months. In healthcare, it will continue to present a considerable drain on our resources, including human resources, as we struggle to reestablish the pre-outbreak volume and scope of care while keeping COVID-19 in check. Between burnout and moral injury, we will continue to see healthcare professionals leave the profession and suffer the consequences, including relational problems, substance use, and other psychiatric disorders. Telehealth will continue to gain ground as an effective modality of care. As a downside, further fragmentation of societies and communities imposed by a lack of travel and personal interaction may lead to currently unforeseeable consequences. COVID-19, although not a devastating pandemic, is somewhat unique because it's the first clinically relevant global outbreak in the last 100 years. As humans, both individuals and cohorts, we have the psychological resilience to sustain and survive much bigger pandemic outbreaks as we have throughout the history. Now, the question for us here and now is, do we, as advanced societies and a sophisticated global civilization, possess the same resilience even when hit by a less deadly outbreak? Or have we lost our collective emotional immunity? COVID-19 is difficult to curb because it's difficult to correctly approximate the risk it poses to cohorts and individuals. There is no known studies or methods to understand the risk appraisal among individuals and populations. There are, however, some instruments such as QoRAS that are used to capture perceived personal risk, but they don't explore how individuals and groups arrive at that decision. So in an absence of a measurement, I developed something that I call heuristic unconscious risk evaluation mechanism, which takes into account the R0, basic reproductive number, case fatality ratio of an illness, prevention efficiency gap as measured in percentage of how what efficiency under 100% is provided by a vaccine, and then the individual weight factor based on both objective and subjective appraisal. And the idea of this is that if the value of this factor is over 1, we tend to perceive it as dangerous and a serious threat, and so we adhere to both public and individual measures that we believe will protect us from it. If it's below 1, then we tend to treat it as a less serious threat and consider it to be similar to flu or cold, and not necessarily put it as a high risk priority in our daily lives. COVID-19 tends to hover around this value of 1, going above and then below, and it constantly makes us, both as individuals and groups, misperceive the risks. For example, in the early 2000s, when COVID first started, this factor was fairly low, fairly high, because we didn't have any vaccine, and we're beginning to implement social distancing measure that were going to affect and suppress the basic reproductive number, or R0. And once we have done that, we have successfully brought this value to under 1. Now with the Delta variant, things are getting a little bit complicated again. But the point is that at sometimes we overestimate and sometimes we underestimate the real threat that COVID-19 is. So what is actually our baseline? It turns out that general population can be affected by COVID-19 before any measures and before being directly exposed to it. In Hong Kong, for example, general population reported symptoms without exposure to COVID-19. Depression in the range of 19%, anxiety in the range of 14%, and 1/4 reported deterioration in mental well-being. In China, self-reported anxiety during opening stages of COVID-19 was 29%. Self-reported symptoms of depression were reported at 37%. And then in some studies, the incidence of reported symptoms reached 50%. Whether or not they're associated with COVID-19 outbreak, we can't fully tease out, but that is the baseline. What are some of the common neuropsychiatric symptoms of coronavirus infections? COVID-19 in that regard are similar to those of other viral infections, namely other coronaviral infections. With the high prevalence and incidence of COVID-19, we now may see more of the conditions we failed to identify during previous limited outbreaks or failed to attribute to coronaviruses. For example, SARS was limited in its scope. What we've seen in other serious coronaviral outbreaks were mainly insomnia, anxiety, memory impairment, depression. In COVID-19, again, we have anxiety, insomnia, depression, but also PTSD and some OCD-like symptoms. With COVID-19 patients, we are dealing with several aspects of complications during the course and treatment. And of course, we start with delirium. There is a possibility, albeit a rare one, of encephalitis. Then there are the neuropsychiatric sequelae, including the longer-term course of COVID, and that leads us to speculate about the possible implication of P2X7 receptors. Psychiatric emotional consequences of the illness, of course, itself, psychiatric and emotional consequences of the treatment, and then, as we said, consequences associated with long or short-term post-COVID course and recovery. Delirium in hospitalized COVID-19 patients is a direct function of severity of the illness. Reasonable estimates between 20 and 30% of ICU patients, some estimates as higher than 60. Delirium rate in COVID-19 is comparable to rates of disease with similar severity and in a similar setting, such as the intensive care unit. In a lot of our cases, however, delirium incidence may have been masked by the use of sedation and ventilation. CNL care during COVID-19, there were several challenges that we had to overcome in the past 18 months. Some of them were constraints in managing delirium with classic agents and with concurrent use of hydroxychloroquine back at one point. Some of them were associated with use of alternative agents with concurrent use, for example, valproic acid with concurrent use of RNA disruptors. Rise in the use of selective alpha-2 adrenergic receptors in managing of delirium was a notable thing. Also to bear in mind, there was a use of interferon and steroids, which come with their own psychiatric risks. So what are some of the next steps that we could look at trying to explore the treatment of delirium in COVID-19? We can consider the use of anti-inflammatory agents, mainly aimed at interleukin-6 and TNF alpha suppression. There was some report of use of these agents during COVID, but there was only one report of a case of using them in delirium. So they have been used extensively or more or less extensively in treatment of COVID-19, but their role in affecting or possibly suppressing delirium still remains unclear. There is a possible role for granulocyte macrophage colony stimulating factor inhibitors because by blocking them, we disrupt inflammatory response at several different pathways, and those may be potentially useful in managing the complex delirium cascade. So you have the inhibition of the cytokine response, limitation of the chemotaxis, cell degradation reduction, and then blunting of the cellular immune response. Some of the examples of these medications are otilimab and others, and only otilimab is being currently used. So while it's available, we may explore some of these agents, this one namely, and try and see how it may affect delirium, both of infectious and non-infectious etiology. This is highly speculative and still remains unknown. Other neuropsychiatric manifestations of COVID-19, of course, anosmia and ageusia were common, observed in at least 1/4 of the cases, and most people recover in a week. There are some rare complications that are direct consequence of viral involvement, but at this point, our main concern still should be stroke and CV incidence rather than these rare diseases. Depression, like delirium, is dependent on the severity of illness, duration of hospitalization, prognosis, isolation, and long-term outlook. It's often a part of this triad of insomnia, anxiety, and depression. It's also being accompanied by pervasive fatigue and loss of energy and motivation. So we are having a definitive developing area of interest, correlation with inflammatory processes and markers. My best guess is that chronic inflammatory symptoms, basically such as various pains, combined with some depression and anxiety and some cognitive fog, are part of this same cluster. Treatments with antidepressants may not necessarily be warranted at first, and focus should be on psychosocial support, overcoming isolation, and facilitating communication with loved ones. If treating, make sure that delirium is not present, and if you just also decide to treat, maybe consider SNRI agents. Also keep in mind drug interactions and the fact that SSRIs have on platelet aggregation. Anxiety is present in a considerable proportion of patients, more than 1/3. It's adversely affected by female gender, older age, although some studies found the opposite, oxygen saturation, and existing social support. So understandably, people who are in the process of surviving COVID are not only concerned and anxious about whether they're going to survive it, but also how are they going to recover and whether there's going to be someone there for them during the process of recovery. There's been some limitation there is limited value in use of benzos for anxiety due to breathing interference, but benzos are generally not contraindicated. Serotonin 5-HT2 antagonism in some medications may be utilized, and if anxiety is co-occurring with depression, then antidepressants may be considered. If observed as a part of delirium, then second-generation neuroleptics with 5-HT2 antagonism should be considered. Traumatic stress, liability for traumatic stress increases with the invasiveness of treatment, such as ventilation, the length of stay, presence of delirium, and prior traumatic exposure. COVID-19 ICU patients should be screened for PTSD and traumatic stress at discharge and provided educational material and referral sources because the rate of PTSD may be so high. Some studies place the prevalence of PTSD among survivors between 10 and 30%. Some predictive factors for development of PTSD is prior mental health diagnosis, but we are still lacking yardsticks at longer-term outcomes post-recovery. It is, however, reasonable to expect that PTSD in COVID-19 survivors will play a hindering significant role in their recovery. Again, understanding lingering inflammatory processes may be effective in understanding post-COVID-19 trauma processing and emotional well-being. Then there is this issue of so-called long-haul COVID-19 or long COVID-19 or post-COVID-19 syndrome. It's an amorphous constellation of symptoms that persist in a percentage of COVID-19 survivors beyond customary 4 weeks, with most experts agreeing that symptoms persistence beyond 12 weeks would warrant a long-haul label. About 5 to 6% of COVID survivors may be experiencing symptoms up to 6 and even 9 months. There are 3 most common symptoms that include shortness of breath, cognitive dysfunction, and fatigue, although there are close to 200 various symptoms reported. The way we approach this long-haul COVID is really variable. Some have entrepreneurially started specialized COVID rehabilitation facilities. Others are brushing patients and their concerns aside. There is no definitive treatment for long-haul COVID-19, and psychosocial intervention, CBT, and medications have been used. Some approaches resemble approaches to extreme post-exertional exhaustion, such as replenishing depleted nutrients, resolving electrolyte or hormonal imbalances, and then carefully starting patients on exercise regimens. Other approaches are similar to approaches to chronic fatigue syndrome or fibromyalgia. There's been noted utilization of inhaled steroids, but also stimulants and wakefulness promoting agents. Again, SNRIs may be a reasonable choice for individuals with persistent inflammatory and mood symptoms. We are now looking at support for healthcare personnel. Anxiety among healthcare workers usually precedes that of general public. We tend to underestimate and downplay the seriousness of a pandemic. However, 10% of us will go on to develop traumatic stress, and then more will have at least some symptoms of depression and stress, up to 50% in China during the first outbreak in 2020. There is a considerable risk for traumatic stress, burnout, demoralization, and moral injury with potentially long-term adverse consequences, which include PTSD, depression, and substance use. Substance use increase can be reported up to 3 years after the outbreak, for example, from the SARS outbreak in 2003. So it's important to have resilience and support programs in place that can help prevent and provide early treatment and prevent the above complications. There are 4 areas that were classified as important using factor analysis for healthcare personnel, and that is health and relationship with the family, relationship with friends and colleagues, work, and spirituality. Some of the issues that were found to be most helpful were clear directives and appropriate precautionary measures, ability to give feedback, ability to get support from supervisors, colleagues, and family, ability to talk to someone, and then religious convictions. Support from supervisors and colleagues was a significant negative predictor for psychiatric symptoms and PTSD. In some countries, such as Singapore, healthcare workers had this unfortunate experience of being exposed to SARS and then 17 years later to COVID-19. So in comparison to SARS, they report that most half of them felt safer and better equipped in the current outbreak. Overall, they report experiencing far less stigma and discrimination and positive social cues during COVID-19 than during SARS. Negative predictors were being a racial minority and living apart from family. Daily exposure to confirmed or suspect COVID-19 cases increased the odds for adverse stress among healthcare workers who had no prior SARS experience. So this tells us that we did tend to learn some things and do some things better this time around. Social distancing, on the other hand, was a massive, unprecedented experiment in the history of humankind. It comes with significant psychological, social, and economic toll on individuals and communities. Prolonged isolation and separation from families and their community can have profound effects on socially isolated individuals. We need to develop a better gauge of psychological effects and limitations to such measures. And I will remind you, back in the day, in the 14th century, when they first came up with the quarantine, there definitely seems to have been a reason that when it was imposed, they limited it to 40 days and it was just under 6 weeks. What are some of the social distancing effects? Helplessness, loneliness, boredom, combined with anxiety, uncertainty, and non-COVID stressors, they will put a strain on individuals, families, and communities' coping capacities. So you have a lack of access to care, risk for both relapsing and developing new disorders, substance use risk, and abusive behaviors risk. When exposed to effects of social distancing, majority of people will see it as a considerable inconvenience, imposition, and disruption. They will view it as confinement and experience boredom, depression because of being forced to stay at home while feeling helpless. And they will experience more self-reported psychological problems. There is, however, a subset of people who concentrate on the positive sides of staying home, and they find it to be responsible behavior and an opportunity for self-development. Those who perceive it as a responsibility or opportunity experience fewer psychological problems. So in this segment, we're still blind people trying to describe an elephant, and maybe we should focus more on how to foster this positive perception and promote self-growth and allow people to have some benefits while being forced to otherwise maintain social and physical distance. Let us focus on some of the major directions for inquiry in the future. The effects of social distancing on emotional well-being of general population and subpopulation still remains an unknown. We need to develop stronger and better resilience programs for health workers as they bear the brunt of any major disaster or public health event. We are learning how to integrate telepsychiatry and telehealth into our practice. We can look at psychoimmunology and immunomodulation and focus on inflammatory components and markers, and also at the very end, look at research and utility of some of the existing drugs in addition to developing new ones. In terms of psychoimmunology and immunomodulation, roles of immune inflammatory response system and the compensatory immune regulatory system have been postulated in etiology and pathology of psychiatric disorders. Activation of immune pathways such as now well-known cytokine storm, autoimmunity mediated by cross-reactivity between CNS components and viral particles, and then microglial activation can have further neuropsychiatric effects and warrant more scrutiny. Accelerate use of immunomodulatory drugs to treat COVID-19 basically will allow us to participate in this learning process. Inflammatory processes have been long implicated as having a role in psychiatric disorders. They may play a role in the post-COVID-19 long-term psychiatric sequelae, directing our choice of treatment modalities. Studying the role of microglial P2X7 receptors in the cascade of inflammatory response, for example, may lead to better understanding of the inflammatory nature of some cognitive and psychiatric symptoms, as well as of neuropathic pain, which we have suspected for a longer while. COVID-19 is an opportunity for investigation of the naturalistic association between viral respiratory infections and psychiatric symptoms. Just to remind you, there are a number of other coronaviruses which freely and commonly circulate among global population, that they cause nothing more than a common cold. But then again, we don't know. Perhaps at this stage, we ought to more closely examine the possible relationship between some of the common viruses and some fairly common psychosomatic entities, such as chronic fatigue syndrome or fibromyalgia. We can invert this and look at it from the different perspective. This past season was likely the mildest season, flu season in modern history. And perhaps we ought to study long-term effects and outcomes of such an unusually mild flu season and learn from some of the milestones at 15, 20, and 25 years down the road. We can also research some of the existing drugs. Here's just a couple of examples. For example, valproate may have some putative effect in preventing cell progression of SARS-CoV-2, as well as haloperidol. Also, chlorpromazine is an inhibitor of clathrin-dependent endocytosis, and that's a key mechanism for the viral entry into the host cells. And it also prevents the subsequent viral genome release and replication. And so there were also studies to investigate the utility of chlorpromazine in treating and preventing COVID-19. We have done a tremendous progress in advancing telepsychiatry, and here is a quick review of some of the challenges associated with remote and in-person encounter, because neither seems to be perfect in these current times. The remote encounter, it may paradoxically, for example, appear more immediate because patients can see your entire face, whereas in patient's room, although you may be there, you have to wear a mask, and patient may be attached to machines. And again, there is no immediacy that you would have in a regular in-person encounter. So side by side here are some of the challenges and some of the features. What are the challenges for mental health services in the next phase? We are adjusting to the shifts in social proximity and distancing, and are adopting flexibility in providing care by using telemedicine, which I hope will lead to reduction in cancellation of outpatient visits, even when distancing measures are done or removed. We continue and have to continue advocate for our existing patients, particularly those with serious mental illness, to be provided with adequate access to care. We need to advocate for research to understand and protect public mental health during this outbreak and its aftermath. And this pertains to both the viral impact and the impact of our public health measures. We have to advocate for behavioral health experts and behavioral scientists to be given a seat at public health panels, from local communities to World Health Organization, and convince the scientific community to redefine epidemiology as, at least in part, a behavioral science. I will leave you with a final question for this presentation. At this stage, given how little we know about the role that emotions, attitudes, and behaviors play in propagating this outbreak, we have to, for a moment, suspend the traditional question that we have been asked as behavioral scientists. How is this pandemic affecting our mind? And reverse the question, asking ourselves, our colleagues, and entire scientific community, how is our mind affecting and driving this pandemic? By learning answers to this question, we can contain the outbreak, save lives, and leave a legacy for the future generations. Thank you very much.
Hi, and welcome to the updates course for Proactive CL Psychiatry for this year's Academy of CL Psychiatry's annual meeting. My name is Mark Oldham, and I'm an assistant professor of psychiatry at the University of Rochester Medical Center. As pertains to this presentation, I have no relevant conflicts of interest to report. In fact, I don't think I have any at all to report, but In terms of where do I fit into proactive CL? Just a couple of words about kind of my engagement and interest in this subject. First off, I'm the medical director of the proactive arm of our consult service at the University of Rochester Medical Center. Our service is called Prime Medicine, which stands for the Proactive Integration of Mental Health Care in Medicine. So we work with hospital medicine teams. And also, I'm the chair of the Proactive CL Psychiatry Special Interest Group through the ACLP. Now, I'm going to have a couple of slides at the very end talking about that, but if you're interested in learning more about Proactive CL, like to kind of understand better about, what does this look like, if you'd like to talk to folks who are currently practicing and really just learn more and kind of get a part of the conversation, please reach out to me. Please join the Special Interest Group. We'd love to have you be a part of our team. Two other hats that I wear, perhaps a little bit less immediately relevant, but I still think important, are treasurer. I'm currently the treasurer of the American Delirium Society, which is the organization that really focuses on scholarship and dissemination of delirium work here, both in North America and South America. We have a special interest group in our organization in Latin America as well. And then I'm also one of the deputy editors of the Journal of the Academy of CL Psychiatry, formerly known as Psychosomatics. So just a couple of orienting comments about this presentation, objectives. So we'll begin with a few slides on what's known about proactive CL. We'll talk briefly about the background and the principles of what this model of care are. Next, and we'll spend the majority of our time talking about what's new. We're going to cover 2 resources published within the last year and also 3 articles in the literature in the past year as well. And then finally, we're going to end with a couple of slides talking about what's next. So what are some future outcomes of interest or unanswered questions, outstanding questions about proactive CL, just to kind of think through what the future of proactive CL might look like. And so just to simplify things, what's known, what's new, what's next, let's start with what's known. So in a phrase, and for those who might not be familiar or as familiar with this model of care, proactive CL psychiatry is an interdisciplinary model of CL psychiatry that incorporates systematic screening for mental health concerns, early clinical intervention, and integration with primary teams. All of these with the goal of facilitating efficient care and improved outcomes. Now, each of these 4 items that I have in bold and blue, these we consider to be some of the key principles of this model of care. And we're going to unpack them over the following slides. Now, I think the high view question that you might be asking is, well, why would we need this? I think most people here probably know the answer to that, but thinking about comorbidity, it is striking that a conservative estimate is 40% of patients admitted to hospital services, medical and surgical settings, have some form of psychiatric comorbidity based on a variety of different studies. And specifically at our hospital, when we were doing the pilot of Prime Medicine, and just looking at chart evidence of psychiatric comorbidity, we found that more than 2/3 of admissions had some form of psychiatric comorbidity, which included a psychotropic, essentially for a psychiatric indication, and also looking at diagnoses in the chart. So again, comorbidity is tremendous in terms of mental health burden among medically and surgically admitted populations. And it doesn't take a great deal of creativity. And anyone who's practiced in hospital settings knows that each of these conditions can impact care tremendously. This is just a sampling. We could make this 10 times longer or more, but essentially every mental health condition can conspire against its own treatment and also compromise the care that patients receive for their medical and surgical conditions, the reasons that they are admitted to the hospital. And then the costs of these mental illnesses, these mental health conditions, are felt really across the spectrum. So we often talk about the hospital costs, which are real, so longer length of stay, sitters and restraint use, poor outcomes, higher readmission rates, but the costs are also very personally felt as well. So thinking about the staff in the hospitals, most clinicians in the hospital are not trained in mental health principles to manage mental health conditions. This can cause a sense of job dissatisfaction or distress. I didn't come into this job for this. And yet the patients they're caring for have a significant amount of mental health need. This can contribute to burnout, and certainly stigma and implicit bias are things that all clinicians are vulnerable to, including mental health clinicians. And specifically, and most importantly, the burden of mental illness is felt by the patients themselves. So where this mental health comorbidity is present, this can compromise care. If patients feel like the providers are not taking care of them appropriately or not listening to them appropriately, this can lead to mistrust of staff. The overall quality of life and quality of care can be compromised. Functional decline could be an outcome. And ultimately, people just don't do as well when these conditions are not managed well and together. So then, drawing from a number of sources, we can apply a variety of principles. These four in the center are kind of the lenses through which kind of proactive CL psychiatry might be understood. And you apply those to general CL practice, you end up with an approach that looks a lot like, and we believe very much like, proactive CL psychiatry. So if we want to do prevention, we need to be proactive in engaging patients. If we want to take a population approach, we need to screen systematically. Teamwork is critical. And so we as mental health clinicians can work as a team. And then also the relationships across specialty boundaries. So medicine and psychiatry, for instance, this is really the substance of integrated care delivery. So what does this look like? Well, essentially, population health, we start by screening upon admission. This leads to a sense of prevention. And so we're going to be engaging early, doing case reviews with teams, curbsides, thinking about disposition and aftercare early, working as a team. So not just a psychiatrist, but also thinking about other professions who might work on that team, and ultimately bridging that care with our primary care and primary team specialists. And I won't go through the details here, but these are some of the data that I've brought together in a systematic review about a little over a year ago. And in general, this model of care is associated with reduced length of stay, improved staff satisfaction, higher consultation rates, and lower consultation latency. And I refer you guys to look at this literature if you're interested in learning more about the history of proactive CL and the data in support of it. But let's turn now to what's new. Let's spend the majority of our time here. And we'll begin by starting with the two resources that have been published in the last year. And we'll start with the APA's resource document on proactive CL psychiatry. And this is published in the Journal of the Academy of CL Psychiatry, currently publicly available. And I would think of this as a practical overview of proactive CL. And if you're interested in learning more about this model, this is probably the best place to begin. What's in it? Well, it provides a review of the history of proactive CL in the context of CL psychiatry, the evidence behind and in support of this model of care, the context, kind of the medical context and social context in which it has emerged. And we're going to look at that in another slide. We consider the different team members, their roles and their kind of responsibilities and how they work together. And then also, what are the future opportunities for this model of care? But here on the right side of the slide, I have a very small table. And this might be one of the main highlights of the resource document. And I'm really grateful to my colleagues at these other institutions who have really helped put this together. So essentially what we've done is we've created a very large table, and I mean very large. I think it covers like 6 or 7 pages. And we've taken the 4 principles of proactive CL psychiatry and operationalized each of them, how they are kind of implemented at each of these sites. So if you are interested in learning what screening looks like, you will find potentially 9 different expressions of what that looks like. And then again, for each of the different principles, they are outlined in this table 3, in the resource document. So this is what I alluded to just a moment ago. This is the context, kind of the hospital trend context in which proactive CL psychiatry has arisen. So first off, in 2007, the Triple Aim came out and focused on patient experience, population health, and per capita costs. Really, how do you tackle these as a bundle? And then, of course, the kind of informal quadruple aim kind of came out subsequently, which included work life of clinicians. But in this context, I think many people now think about interventions and implementation work in hospitals and other healthcare settings differently. And so in this context, proactive CL, I think, fits very nicely. Hospital medicine, the subspecialty of internal medicine that practices in hospitals, is really 20 to 30 years old. It is a relatively recent origin. And in fact, the American Board of Hospital Medicine began in 2009. So again, the idea that you have dedicated clinicians with a hospital-based expertise, really working toward efficiency, better care integration with other services in the hospital, is a relatively new model, and I think also deserves consideration. Mid-level practitioners have also been increasing in terms of their presence in hospital settings. And as of 2018, 3/4 of hospitalist programs in the US employed mid-level practitioners. Integrated care models in outpatient settings have been expanding and really taking off, including with CPT codes for care management services. But I think this really, this introduces the question, well, what about a corresponding model in the hospital, right? These collaborative care and integrated care models tend to be outpatient. Well, what do you do inpatient? And I think in many ways, proactive integrated care is the answer to that question. And then kind of the capstone of all of these, value-based care, thinking about incentives and how do you really improve broadly the care being provided as well as the outcome. So again, in this context, I think proactive CL is very well situated to answer many, if not most of these, if not really all of these. And it certainly is early enough and nimble enough to address these as they continue to evolve. And then just to show this table as well, I think it's important, but just to refer everyone to it if you're interested in learning more, these are different team members who might be a part of a proactive CL service. Now, as this was developed originally at Yale, specifically the behavioral intervention team I'm thinking about, it was implemented as a psychiatrist, a nurse practitioner, and a social worker. But across the spectrum of proactive CL services, a variety of other team members have been added. And really, these should be tailored to the population, to the outcomes of interest, to the personnel and staff who are available, really tailored to the setting in which it's being implemented. So that was the resource document. Now we turn to the CL Psychiatry Advocacy Toolkit, which I've completed and developed in collaboration with my mentor, Dr. Lee, who has been a champion for proactive CL for many years now. And so what is a CLP advocacy toolkit? Well, the purpose, according to the CL Psychiatry website, the Academy has developed executive summaries and slide sets that provide evidence of the importance of including CL psychiatry physicians in the delivery of medical care in all settings. So this is really the kind of background for what an advocacy toolkit is, and really the spirit in which this toolkit was developed for ACLP members. So there is a slide set and a corresponding executive summary. The slide set includes a discussion of unmet needs in hospital settings, presents a kind of a general business case for why proactive CL makes sense financially for the hospital. It also gives an overview of daily operations, kind of general workflow, and then also has a few words about future horizons for this model of care as well. And the executive summary provides a slide-by-slide description or perhaps narrative summary so that it's almost as though you're kind of watching a presentation, but you can read it for the purposes of engaging with the material. All right, so those are the two resources. Again, the resource document and the CLP advocacy toolkit. And now we turn then to the 3 peer-reviewed publications that have come out in the last year relevant to proactive CL psychiatry. And the first here is by Joseph Kugler and colleagues, published in Psychosomatics at the very end of 2020. So Dr. Kugler and his team did something that they called modified BIT, or modified behavioral intervention team, which was an embedded psychiatrist in a community hospital where they modified the way in which kind of daily workflow kind of operated. And so that psychiatrist would work with the social worker and other team members in the hospital to screen patients and also to be proactive in engaging with patient care. And I'll note, this is the first study of its type in a community hospital. And that's important because 75 to 80% of care delivered in hospitals across the country are in community hospitals. We talk a lot about academic hospitals, and that's important. But if you really want to reach kind of the broad population in the US, community hospitals are really, again, I think that the primary place that we should be thinking about as we really consider what dissemination looks like. But in this model, in this study, it was an ABA design. So there was a year pre-implementation phase, a 3-month implementation phase, and then another year afterward overall. And so here, when you look at the consults themselves, in the first here, we have length of stay among consultations before, during, and then after. And so you notice that during the intervention, those patients who receive psychiatric consultation, the average length of stay appears to be lower. And you see on the table here, the average length of stay was 3 days. Next, on the second portion of this figure, this here is consult latency. So this is time from admission to the point that a consult is ordered. And so it dropped from 2.4 days to 0.8 days. So again, substantially faster, really getting to patients, being proactive, and early care involvement. And also, I'll just highlight here in the table on the right, the consult rate increased markedly. And I think that's putting it mildly, that it increased to 33% during the 90 days of this implementation phase. And what I find interesting too is after that, the consult rate increased over the following year to 6.5%. So something was catalyzed by this involvement, by this intervention, so that clearly there was a greater interest and kind of a greater engagement with psychiatry in that hospital. So again, I think early data, but broadly favorable. And thinking about staff satisfaction, confidence, responsiveness. So these dark gray bars were pre and the light gray bars were post. And so you just kind of see in the Likert scale that things shift from pre to post toward very and extremely satisfied overall across the board. So clearly the staff very much appreciated having more and more kind of proactive mental health care available in that hospital setting. The next study that I'll be presenting is one that I published with a few colleagues earlier this year. And so this is really the overview of Prime Medicine, the model that we have at our hospital at Strong Memorial Hospital. And so I won't be providing kind of granular details. There might be a little bit more information on some of these slides than I'll have time to cover here, but just to hit some of the highlights. So we implemented a proactive service across 3 hospital medicine units, staffed by mid-level practitioners, so nurse practitioners and physician assistants. And we used as our comparison 2 teaching resident units, similarly staffed in terms of nursing and similar size as well. They're all on the same floor of the hospital. We defined the intervention period as the 10 months of the year of when we began this intervention, and then we used the corresponding months over the prior year as a historical comparator. Here you see our exclusions, some outliers, and other factors that we would not be able to change. For instance, an eating disorder protocol was instituted over this time where patients coming in for refeeding was kind of defined as a 14-day admission. So that was kind of already set. It's not something that we would be changing. And then our primary outcome was change in length of stay. And we used a model called difference in difference. So essentially we took the change in length of stay pre-post in our population or our cohort, our 3 units, and we subtract from that the change in length of stay on the comparison units. And we're adjusting for relevant covariates. And that's a pretty robust way of evaluating the effect of this intervention using a comparison unit to kind of account for contemporary trends. Secondary outcomes included consult latency and volume, and then also nursing attrition as well. So in terms of consult latency, we did not improve consult latency by much, 0.2 days, really not significant. However, what we found in looking at the data is the average ED boarding time was 1.9 days. That was from the time of admission order to the time they hit the floor. So unfortunately, that really introduced kind of a period of time that we could not engage with patients. And it's something that actually, since the pilot phase, we've been modifying so that we can ideally get to patients sooner. The consult rate leapt up from 1.6% to 7.7%. And if you just look at the comparison units, the consult latency increased slightly, not really substantially. The consult rate did increase, but certainly not to the degree that it did on the intervention units. In terms of nursing attrition, it's very difficult to really know, to what extent our intervention had an effect. These data were available in aggregate, so there's no way to identify who is who. But kind of looking at a very high level, we looked at the reasons that nurses gave for leaving these units, either prime units or comparison units, over the year of the intervention. And of the buckets that nurses could give, patient population was really the only bucket that we thought that we might have some impact on. And although the overall number, the absolute number of nurses leaving units, our units and also the comparison units, increased during our intervention, it increased less on prime units than it did on comparison units. If you look specifically at those nurses identifying patient population as the reason for leaving, that actually decreased from pre to post, and then increased substantially on the comparison units. So I would say that's a favorable trend. Again, we can't really, don't want to read too much into it. However, we did report this because it was part of the business improvement plan that we were looking at for the value of our proactive service. Now, length of stay is a really difficult thing. It has a lot of kind of tributaries to it. We did not improve absolute length of stay in this study. But looking at the difference in difference models, when you look at the marginal effects model and then the adjusted regression model, the length of stay was reduced. And if you look at the fully adjusted model, decreased by 0.16 days overall. And this is really accounting for all the variables that we could. We actually could not account for length of stay, the ED boarding time, because we did not have those data for all patients. So it would have kind of biased the model in that regard. And also, we did not have, for the purposes of this evaluation, specifically those individuals who were discharged to a higher level of care, which was higher during our year than it was the prior year, and also higher on our units than the comparison units, which we also think likely contributed to our outcomes. We did look for trends, and on 2 of these 2-month blocks, we noticed a statistically significant decrease in difference, the kind of that adjusted model. They were statistically significant. Interestingly, the first 2 months, we actually had a slightly higher. So it did look as though, as time went on, as we kind of developed greater rapport, the integration kind of improved, we did find an effect. And so overall take homes, we had no more than a modest length of stay reduction in this. But I would say whenever you're doing a non-randomized trial, you really need to consider the hospital context and the workflow for understanding the outcome and kind of the nuances of that model and of that analysis. We did find that in terms of the consult characteristics, we certainly found that there were unmet needs, that we are now currently far more engaged with these services, and also a favorable trend in nurse attrition. So I would say more to come, but broadly kind of interesting results. And then finally, I'll be covering this as a highlight. This is a systematic review published by Dr. Toynbee and colleagues looking at randomized clinical trials of screening prompted psychiatric CL services. I know that sounds like a lot. We'll get through exactly what that means. So they wanted to see what high quality evidence exists in the literature in support of kind of a proactive approach to CL psychiatry. So they started looking at their initial search, 16,000 titles. They whittled that down, found ultimately 8 papers. And these are the eligibility for inclusion in randomization across the included studies. So they were positive for some combination of depression, confusion, anxiety, pain, positive for probable psychiatric illness, or patients with a safety sitter. So a pretty heterogeneous cohort across these 8 studies. And so here we see in terms of the results, the most recent included study was from 2007. And again, just as a reminder, the triple aims were first introduced in 2007. So again, this is really a prior era in hospital practice. Half of all studies were in geriatric populations, which I would say may affect the generalizability of some of these data. Interestingly and strikingly, all primary outcomes were negative. 2 of the secondary outcomes were positive, and 1 they had a lower depression score at the end, and in 1 they had higher satisfaction with care. But really interpreting these data, I think that's the interesting thing. So what do you make of these findings? So, I think a cynical view would be, well, these models are just ineffective. Perhaps, but I would really point to some of the nuances of the methodology and the methodological shortcomings in and across these studies. And I think the biggest question I would ask is, were the recruited patients likely to benefit? So if you include patients who have depression, do we have antidepressants that work over the course of 5 days? Well, if we're not introducing esketamine into the hospital, maybe not. And so we really need to be careful about the populations that we're including in these studies and kind of matching those to the outcomes of interest. And do we really have, effective or efficacious interventions for these populations? Across studies, there's an uncertain quality of CL psychiatry delivery. It's unclear if it's possible to be replicated as such. There could be possible contamination bias in comparator arms, which is not entirely clear in some of the studies, and the limited power as well due to sample sizes. And I think overall, what this review shows us is that we need more rigorous studies overall in this space and thinking about proactivity. So what's next? 2 quick slides. One, outcomes of interest to be explored further are myriad. This is just a kind of a highlight, a sampling of them. So financial impact beyond reduced length of stay. So thinking about the cost of sitters and security, nursing turnover and onboarding costs, readmission rates, enhanced RVU, thinking about satisfaction. We've talked about providers and nurses, but what about patients and families and patient-reported outcomes? Medical staff burnout and performance, really drilling into patient symptoms, functioning, and outcomes, really matching an intervention to the outcomes of interest. What about care quality? And really, I think in many ways, the holy grail is integrating across levels of care. So really integrating inpatient and outpatient services, ensuring that patients kind of almost have like a medical home, right? They really have good, clean handoffs across levels of care. And I think in this space, many questions remain as well. So which elements of proactive CL are required and for which benefits? Are there more effective ways of operationalizing the principles of proactive CL? What other principles have we not articulated yet? What about patient-specific factors and hospital contexts that might actually modify the benefits of an intervention? So maybe post-operative care would be more financially beneficial and also better in terms of functional outcomes for ambulation and the like. And what factors are associated with successful implementation and delivery of proactive CL models? Again, I just highlight these as open questions, and I encourage people to dive in. If any of these questions, really interest you, please dive in, ask questions, join with us. We'd love to be kind of part of a collaborative engagement where we answer these questions, we explore them jointly. So just to conclude, again, I just want to highlight the special interest group. We have a regularly updated special interest group webpage on the CL Psychiatry website. This is the home page, but if you select Resource Center, that will take you to resources. And we have assembled a variety of materials across sites from different hospitals and settings that are practicing in proactive CL, which have a proactive CL service. We do meet currently every quarter. We have a Zoom meeting to kind of bring people together to have conversations about what's the latest, how are things going across the country, how are you doing, asking questions, getting input. And there's also a listserv. So if you wanted to have kind of a professional consultation and you wanted to talk to somebody who's currently practicing in this model, we'd love to pair you with someone who could answer your questions as well. So with that, I think that's the conclusion of this presentation. Again, I really appreciate your time, and we'd love to have you join us as part of the special interest group. Thank you very much.
Hi, my name is Dr. Javier Jimenez, and I'm here to present a presentation on chronic pain for the CL psychiatrist, a brief review, and recent updates. I have no financial or other commercial disclosures to make. The objectives for today are to appreciate the role for CL psychiatry in assessing and managing chronic pain, review the neurobiology and behavioral psychology of chronic pain, explore treatment options, as well with an emphasis on psychopharmacology. So before we get into it, I wanted to offer a little bit of context as to why I'm presenting on chronic pain as a CL psychiatrist. First of all, I'm a psychodynamically informed, behaviorally interested CL psychiatrist with an interest or an affinity in atypical medical presentations, whether that be abnormal illness behavior, somatoform or conversion disorders, factitious disorders, primary and secondary gain, even personality disorders, and covert complex trauma. But also in doing things that are traditionally CL, like cleaning up polypharmacy, treating delirium, addiction, etc. And I was invited to run a chronic pain department despite really no pain management training, and quickly appreciated that CL psychiatry has a role here and is well prepared for this work. And I became pain and addiction boarded through that process. And in that setting, I offered treatment in 3 modalities. One was the traditional inpatient CL setting where I did pain psych consults, blending psych, pain, and addiction care. Another was admission to and treatment during our chronic pain intensive outpatient program, or our chronic pain rehabilitation program, where I worked as a medical director and offered oversight and did med management while patients got other treatment through psychology and PT and whatnot. And the third one was just individual outpatient cases for ongoing detox or med management, or both. So I wanted to present this as context as to how I got here. It's a roadmap if one is interested in chronic pain management. So should CL psychiatrists be managing pain? I would say perhaps not acute pain, but chronic pain, yes. If the target is chronic pain, then there's a role. I think that we as CL psychiatrists are equipped to recognize and manage psych comorbidities when others are not. Thirdly, we are adept at psychopharmacology and detox, which is highly relevant actually for this population. Fourthly, within psychiatry, we're the best equipped at translating things that are medical in nature, whether that be pain or neurological symptoms. So I think with that argument in place, my experience, but also those pointers, I would invite those reviewing this talk to get involved and to become more trained and prepared for chronic pain cases. But in order to do that, you need to have some knowledge base, and maybe it's important to start to define what pain is and then get into some management techniques. So pain is defined as an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. Notice that it's both neuronally mediated sensory phenomena, but also cognitive, emotional, and behavioral. The function of pain is to protect us against injury, and so it provides a sense of memory, if you will. And so there's evolutionary value in that. And the intensity of pain that we experience is really based not only on the information between the body part and the brain, but also upon our emotional and psychological reaction to the symptom or the event. And that's where psychiatry comes into play, is understanding pain as an experience. Chronic pain as a cross-section only is a failure. Acute pain, you may get by because you assess somebody's pain on a scale from 0 to 10, and you use pure or real analgesics, and you may get by and you get some relief. But with chronic pain, by that meaning pain lasting 6 months or longer, maybe years in some examples, it really doesn't benefit the patient to treat it as analgesia or pain relief. So you're back to square one if you're exposing somebody who's probably not a good candidate to opioids or true analgesics. And so you really need to understand pain more broadly. Chronic pain is defined as pain lasting greater than 3 to 6 months from an acute incident, insult, injury, or surgery. Acute pain should resolve with the expected healing process, but chronic pain is maintained by something unexpected. The image on the right is a bit busy, but it basically is a biopsychosocial review of the risk for chronic pain, things that are genetic, environmental, and otherwise that can put somebody at risk. I invite those reviewing this to read about the things that are risk factors for chronic pain, such as trauma, genetic loading, previous psych illness, features of the pain, etc. There are complex processes and comorbidities involved in chronic pain, particularly refractory disabling chronic pain. Biologically, there are things like ongoing physiological enhancement or neural enhancement. There's central sensitization, which is a process we'll talk about. There are comorbid diseases. There's physical deconditioning. All of these things are purely biomedical. Psychologically, there are certain traits that can worsen the predicament: catastrophizing, avoidance, comorbid depression, anxiety, insomnia, you name it. Socially, there are environmental and relational factors that can prolong disability, like unemployment, disability status, family effects, enablers, things of that sort. So you have to consider all of these dimensions really when you're balancing out a case. Very briefly, we'll talk about pain psychology. This is all review, and then we'll get to some more recent updates and management. But pain experience is very important for the CL psychiatrist approaching a chronic pain patient. You have to try to understand or phenomenologically appreciate what they're going through. Pain experience or perception is a combination of physiology and psychology. It's not just the pain signal that they're experiencing physiologically, but also their psychological overlay. And the central diagnostic and treatment question is, how much of this is directly due to a physiological problem, to a psychological problem, or both? Not to suggest psychogenicity necessarily, but to suggest that in every case there's probably some of both. The question is, what is the balance in your specific case? And obviously, if it's predominantly psychobehavioral, then you're going to have to do more of behavior modification, psychotherapy, psychiatric management, and other things. An important experiential version of pain that you should be aware of is pain as a threat. So pain can be experienced as an unpleasant sensory phenomenon per the definition we shared earlier, but also emotionally as a scary, frightening, even threatening phenomena, and that can threaten bodily integrity. This can activate vigilance and worry and lead to a cascade of psychological problems. And even if the patient wasn't really coming to care for psychological support, it could be that that's being neglected and overlooked by the pain physiological experience. Pain psychology is very relevant to the pain experience. This image on the right is very important, perhaps one of the most important in the entire slide deck, is to understand how people can deviate into different modes of recovery. The mode on the right is that of somebody who has been injured or has pain experience due to surgery or some other activating event, but no pathological or maladaptive thinking patterns, and therefore confronts movement and recovery and does pretty well. The group on the left, however, does not do so well. Their pain experience is the fork in the road. Maybe it's a negative one with catastrophizing, fear, depression, hopelessness, maybe even anger or injustice. And that person, unfortunately, has pain-related fear, avoidance behaviors, disuse, deconditioning, and further disability, which of course only makes the pain worse and only feeds a vicious cycle. You can see this population being often informed by risk factors like previous psych conditions, ongoing stressors, trauma, things of that sort that influence how this person kind of emerges from this pain experience. Getting into the neurobiology of things, you need to appreciate that your patients may have normal or abnormal pain signaling modes. And the one that we obviously get called for is that of a sensitive pain signaling mode, not so much a suppressed or a normal one. So these are people who have exaggerated responses to benign stimuli and excessive protection against further pain or damage. And unfortunately, they're just hypersensitive in a somatic kind of way. And you can see manifestations of anxiety or severe avoidance, or even a sort of version of somatic PTSD in this population. Central sensitization was mentioned earlier. It's a neuronal phenomenon involving abnormal and intense enhancement of pain in the central nervous system, characterized by both allodynia and hyperalgesia. It's important for you to review what these terms are. It's jargon in pain medicine, but it's always going to equip you as a psychiatrist to know these, because if you approach a patient and have an understanding of pain processing and pain symptoms, then they're going to look at you differently than if you come at them and only speak about stress. This is a big part of the review today, or really becoming any sort of physician treating pain, is being adept at the neurobiology and the medical jargon that is used to characterize pain. Hyperalgesia is excessive pain sensation, caused by stimulus that is meant to cause pain, or by stimuli that are meant to cause pain. Allodynia is a pain sensation caused by stimulus not meant to cause pain. So light touch, for example, abnormally causes pain. There are certain physiologic phenomena that you can read more about, and there are references here that you can review if you want to learn more about it, including pain windup and temporal summation, very technical phenomena that happens at the neuronal level in the spinal cord, for example. But suffice it to say, these processes can take a life of their own and exaggerate pain responses and experience. This image shows central sensitization from the top down or from the bottom up, however you'd like to see it. Starting from the image of the hand, this is a nociceptive inflammatory example of somebody with rheumatoid arthritis who has peripheral sensitization of the neurons and nociceptors with a neuroinflammatory environment of sorts. However, as it crosses into the central nervous system, the spinal cord, and then eventually the brain, it interacts with different phenomena and different modulators. From the top down, you also have some cognitive emotional sensitization that then produces the phenotypic expressions of hyperalgesia and allodynia. Hyperalgesia and allodynia really can account for the descriptor for most pain states that are sensitive. You can even think of fibromyalgia or migraines or chronic back pain as forms of hyperalgesia. Maybe these are individuals who have a certain amount of objective neuronal pain, but their experience of it is amplified or hyper. And so you can think of, for example, when you apply pressure in somebody's soft tissue in fibromyalgia, 9 out of 10 people won't have pain, but that person has pain. So that's a hyperalgesic response. Another example or another image, and these are all offered for you so that you can educate yourself, but also either family members, patients, or other providers, is an explanation of normal sensation in the nociceptor, as you can see, an action potential that activates pain with noxious stimuli here on the left, or low threshold mechanoreceptor light touch activation that results in touch. This is normal. However, in central sensitization, you're going to see hyperalgesia or an excessive pain phenotype, or even allodynia rewiring, where something that is meant to not cause pain, like light touch, clothing, even the wind, sometimes light touch can cause pain. It's important for you to have these images in your head and sort of ready to go to explain to patients and buy their confidence in you helping them manage their pain. One more image that looks at the entire pain processing pathway includes a periphery here, but more so includes the central nervous system. As you can see, the spinal cord has an entry point in the dorsal horn, and then an ascending, pain signal pathway that is interfacing with your sensory relay station in the thalamus. And then there's a descending pathway, the periaqueductal gray, with your endogenous endorphins and other pain relieving neuropeptides that descends and actually inhibits pain. For your purposes as a psychiatrist, it's important to understand that these central nervous system structures, the brain and the spinal cord, they're really where your interventions are going to take action. We'll talk about that later in management. The other psychiatric model that is important to appreciate with chronic disabling pain is that of PTSD, and thinking of the repeat hits that people sometimes have and the kindling that occurs after PTSD or severe trauma. And the same thing can happen with severe pain. If pain is experienced as a fearful process and it is bombarding the individual day in, day out for months, years, then you can imagine that they're going to become quite hypersensitive, quite vigilant, avoidant, etc. And so a lot of the symptoms that you see in PTSD in a somatic sense will occur also in a chronic pain patient with that kind of pain experience. And there's actually evidence to suggest that there are strong neurobiological similarities in PTSD and chronic pain via central sensitization. There's research and references, again, that you can review later. This is a simplified version of sensory input coming into your body, but with the model of PTSD, a presentation of a dangerous situation visually, auditorily, activates the sensory thalamus, and through subcortical, very crude, rapid onset shortcuts, activates the amygdala, which then results in a fear response and a cascade of events. There is also a sensory cortical pathway, but that is a slower, evolutionarily newer process that may not be activated if somebody is in threat mode, and with good reason. It's meant to really provide survival when something threatens bodily integrity. You don't need your cortex to think about your options when something dangerous is presented. If we use pain as an example, and this is where the cortex, is sort of blocked out and you're operating at a subcortical level. If pain is really the stimulus, you can see the activation of the same pathway. And the fear response may be a little different, but it's comparable in terms of pain behaviors that are very dramatic, that don't match up with the syndrome, or physiologic effects, or even central nervous system outputs, including adrenergic changes. So you see all of this phenotype in your complex chronic pain patient that you see on your consults. The explanation may sometimes be this sort of somatic PTSD experience. Now let's get to management. Obviously, when you have somebody with chronic pain for years or months or a very long time and significant disability and significant comorbidity, the emphasis should be on chronic pain management, not necessarily eradication of pain. And this is a paradigm shift that a lot of patients aren't even ready for. Many of them keep going for diagnostics or specialists or consultants or tests or surgeries or other interventions to try to eradicate the pain. But sadly, some people will have to live with the pain, and that may be a very difficult pill for them to swallow. Chronic management of the pain so that they're not further disabled from the pain and they manage the pain instead of the pain manages them is really the goal. So that already requires a bit of mental judo and a little bit of a paradigm shift. The target is not cure, actually, in many of these examples, but rather is rehabilitation. If you find that a patient really isn't functioning, doesn't have a quality of life, they have numerous side effects from their interventions or in and out of the hospital excessively, then maybe it's step one is reframing what their goals are. Ask them, what is it exactly that they want to be healthy and pain-free for? Is it to hold their grandkid? Is it to go back to work? Is it to interact with their loved ones? Keep their eye on the prize, if you will, in terms of motivation. You can hear the elements of MI in their motivational interviewing, and that's important because otherwise you're just going to keep circling the drain looking for cures. And other models, of course, can be used like acceptance and commitment therapy. Medically, we can do pharmacological, graded detox, and proper psychiatric diagnosis and treatment interventions to help the patient. And this is really what the bulk of the rest of the presentation is about. Physically, we can suggest reconditioning, graded exposure to movement, things like that, so they can confront their avoidance. And psychologically, of course, there's a lot of work that can be done in this population. But for the CL psychiatrist, I do want to focus on that first medical group. You do have to manage all three. So convincing them that they have to do this in concert is very important. For pain psychopharmacology, you have to realize that there isn't really a well-organized field. A lot of pharmacological creativity is the norm, not the exception. And off-label use of medications is very common. The first order of business is to remove barriers, such as benzos, opioids, and or marijuana. We'll get into that in a second. Then you have categories like SNRIs, TCAs, anticonvulsants, antipsychotics, and even sympathetic modulators. So let me review that with you today. And finally, Suboxone as well. I'm sorry, we'll review that as well. So the first thing is to do less harm or no harm. Obviously, it's easier said than done, but when somebody's on chronic opioid therapy and they're not doing well and they still have chronic pain disability, then maybe the first step is to remove those or at least minimize the total amount of opioids. We all know there was an opioid epidemic and there's a huge consensus now to not utilize opioids liberally in chronic pain. And the most recent guidelines from 2016, the CDC guidelines were very powerful in affecting this and changing practice. So that's a good thing. But you need to have an approach for this. I typically will tell patients that, yes, there's addiction and there's all these policies and all of that, but rarely do they really relate to that because they don't think of themselves as addicts, etc. So really what I try to talk to them about is these other things that are associated with opioids, like other medical problems, like CNS suppression, falls, cognitive issues, depression, etc., immune effects, GI effects, the social and logistical burdens of cost and time and stigma associated with chronic opioids. But the biggest one for the purposes of today's talk is actually opioid-induced hyperalgesia. If you explain to patients that opioids are actually an obstacle to their pain management, paradoxically, then you may win them over to get rid of them. It's convincing them that actually these pain medications paradoxically are worsening your pain. And that's an important thing to do. There's literature that shows that opioid-induced hyperalgesia is a very real thing, that people not only become physically and psychologically dependent from these medications, but pain worsens over time. So there's a powerful argument to be made there. You can use other language, but basically you need a complicated blend of MI, neurovalidation, where you buy their support or confidence through the neuromedical talk that I was just sharing, being confident around pain and everything, and then offering some adjunct pharmacology and some time, of course, to detox the patient. Whether that's something you do or somebody else does in pain management or whatnot is TBD, depends on your system and your setup and your bandwidth, but it's very important to set up the expectations early on. One hard recognition is that there's really no shortcut to opioid weaning. It requires specialized consultation, communication, and resources. If you're interested in sort of understanding that, people have written about that, and you can review these references. Interestingly, the opioid guidelines actually have resulted in some changes in prescribed opioids over time. So, good things are happening in that direction, so by way of update. The second barrier is benzos. Benzos, as you know, we use them in psychiatry. CL psychiatrists don't love them because of their deliriogenic effects, and we treat a lot of delirium. But in psychiatry, there's a lot of folks who take chronic benzodiazepine therapy. And actually, it's been shown through studies like this one that benzos predict opioid use better than pain itself. That should read, does pain itself. So in a large study, population study, it's actually been shown that there's some kind of relationship here. People who are taking benzos, whether it's because they have anxiety, PTSD, addiction, both, they are at very high risk for then crossing over and taking opioids. There's something about that central nervous system suppression. Again, maybe it's their trauma, maybe it's that subcortical pathway that is running amok. Something's going on and they're trying to check out. And as a result, maybe the benzos develop tolerance on that, and then they start switching over to opioids. And as we know from the CDC guidelines, again, co-administration of benzos and opioids are quite dangerous. They have synergistic effects and actually account for many of the unintentional overdoses that we've seen. So removing these or lowering these is a priority. There was another study that showed that patients on chronic opioid therapy had 12.5 times the odds of being prescribed long-term benzos. So you can see there's a hand-in-hand relationship here. And so do your part if you can as a CL psychiatrist. If you see one of these complex cases, educate them, their providers or family, whoever, about the harms of this. If you do only this, that's already a home run. You're already engaging in pretty significant public health intervention to reduce the mortality in this population. The third group, which is less dangerous, is cannabis or marijuana. Controversial because there are some lines of inquiry that suggest that there's a role for cannabis or marijuana or CBD in pain management. However, the evidence is pretty poor. I've written an editorial to this effect. Really, there's a lot of problems, as you know, in CL psychiatry with the use of unregulated marijuana or cannabis, whether it's affecting motivation, cognition, mood, whether it's causing hyperemesis, as we've seen in cannabinoid syndromes, or if it's tipping some people actually into frank psychiatric states, those with genetic loading and who are young, who then use significant amounts of opioids. There's a significant amount of concern with this. Is it better than using chronic opioids? Probably, but you need to still weigh the pros and cons with this strategy. And if you're interested in reading more about it, again, the references are listed. But let me get to chronic pain psychopharmacology, which is really what we have the most control over. We may have some control over reducing benzos and opioids and marijuana, but we also have various agents that we can use. This diagram depicts the different classic anxiolytic, analgesic, and antidepressant agents and some of their overlaps. Some are only anxiolytic, some are only analgesic, and some are only antidepressant. And then there are those who have dual role. Those that are dual role, I think most people are aware, or triple role, like the TCAs and SNRIs. But we'll review these categories in a second. When it comes to antidepressant responsive pain, there's many examples of things that can respond to pain. Not every patient will, but there's so much out there beyond the scope of this talk. But you should be familiar at least with some of the conditions, whether they be neuropathic or musculoskeletal, for example, or functional somatic syndromes that do respond to some degree of antidepressants. What you should know about the mechanism of action with antidepressants is that those with norepinephrine and serotonergic activity are the ones with the greatest odds of helping. And this is why TCAs and SNRIs are candidates. The reason for this is because there are actual descending pain pathway mechanisms that need to be activated by these meds. If you recall earlier, I was showing the diagram of the brain and the spinal cord with the ascending and descending pathway, and I mentioned that CL psychiatry has the opportunity to modify one of these areas. our area that we can modify, our claim to fame, if you will, is that descending pain pathway through the use of TCAs, SNRIs, or really any medication that acts on both 5-HT, serotonin, and NE, norepinephrine. SSRIs, thus, are mostly ineffective in pain management. And again, this is that image that I was sharing. This is our lever that we can manipulate pharmacologically, if you will. I and some other colleagues recently wrote a clinician-friendly narrative review of TCAs. They're not to be discarded. Again, another class of medications that CL psychiatrists don't love because of their QTC prolongation and deliriogenic effects in the elderly, not to mention other side effects and lethality. However, if used cautiously and carefully in a younger population with less comorbidities and with proper monitoring, you can achieve some good effects. This chart is just meant to be a reminder of some of the features of the different medications and their dosing ranges. This second chart from the same article, and you can review that in the references, shows a variety of indications that these medications can be used, whether it's headache, neuropathic pain, chronic low back pain, fibromyalgia, IBS, cyclic vomiting syndrome, chronic pelvic pain, and insomnia. Of course, there are side effects and precautions to take into consideration. Very important to look at these columns and to be careful, but we have to do that with all of our meds in psychiatry, so you shouldn't think of these as inherently different. When it comes to SNRIs, there was a high enthusiasm over these medications because they are inherently safer, particularly in overdose, than TCAs, and they held the promise of having some efficacy like the TCAs in the sense of having two neurotransmitter actions, norepinephrine and serotonin. Unfortunately, over time, Cochrane reviews and other systematic reviews haven't really shown great effects with these medications, believe it or not. There's a myth out there that maybe we should just put everyone on SSRI, or SNRI, excuse me. And actually, duloxetine and milnacipran are not significantly better than placebo in a variety of pain conditions. So it's just something that I want to share with the group, not to burst your bubble, but just to suggest that maybe you got to think more or beyond, Cymbalta, which is essentially in the water. That being said, there are some people who may respond to them, and the downsides to these medications are low. I will say that one downside is maybe replacing a better anxiolytic or antidepressant medication with one of these, because you think I can cover two or kill two birds with one stone. There is a downside to that, because maybe somebody's well-controlled pain, well-controlled anxiety or depression suddenly becomes less controlled. But these are the SNRIs. You should be familiar with them, of course, and they may or may not have a role, particularly in your mild to moderate cases. As I was just mentioning, SNRIs, Cymbalta in particular, is sort of in the water, right? Everyone's prescribing them because clinicians find something very pragmatic about treating two conditions with one pill or one medication. But please think more creatively, especially if you're at an academic tertiary care center or you're seeing very complex cases or moderate to severe cases. Cymbalta is okay for depression, as we know as psychiatrists, but it's frankly pretty mediocre for anxiety, and it's sort of okay for pain. Remember that systematic review just showed us. So it's reasonable for depressed and mild to moderate pain cases, but really not reasonable for other psychiatric concerns or severe pain cases. And most of our cases that we get referred to or see consults for on the inpatient side are really not going to be Cymbalta responsive, if we were honest with ourselves. Instead, look at the psychiatric priority. You might learn that somebody's already on Cymbalta, for example, and that some well-meaning rheumatologist or neurologist or primary care doctor stopped their Zoloft or stopped their Prozac. And unfortunately, their pain is getting worse, not better. Well, maybe it's because their anxiety is now not controlled, and the uncontrolled anxiety is informing the pain. And as we know, chronic pain and psychomorbidities are very commonly associated. So we should walk around assuming safely that maybe half of the people that we see with chronic pain will have either an underlying depression/anxiety or something that has already been addressed. A word on SSRIs. I mentioned earlier that they don't have a mechanistic value in pain reduction, but here's where, again, thinking as a CL psychiatrist and looking beyond the pain manifestation and looking beyond acute pain or analgesia, it's very important to understand if the person has a an uncontrolled anxiety or depressive disorder. It may be that aggressively dosing with an SSRI is the ticket to reduce anxiety, catastrophizing, fear-based responses to the pain. And it may liberate the person to then do more PT or to confront movement or to go to therapy or to get out of the house. These are all things that are then going to indirectly impact their pain positively. I would avoid being ginger with very anxious patients like this. I would dose aggressively, assuming, of course, you watch out for things like serotonin syndrome and whatnot. But it's important that you do this, otherwise you will lose them to the effect, and try to have them hang on in there with you, despite them being preoccupied with the pain. Invite them to imagine that maybe this route will help them have less attention to the pain. And so think about that as a psychiatrist, and sort of dousing that, again, subcortically mediated pathway. A quick word on bupropion, which is featured here as a pure antidepressant with very little analgesic and anxiolytic effects. It's true that there's really no role in chronic pain except for dealing with some comorbidities like severe fatigue and severe depression, of course, as you might see in certain pain syndromes. As far as anticonvulsants, a next class, we have also a number of neuropathies and other conditions that can benefit from consideration of anticonvulsants. We're going to quickly go over those. You have sodium channel blockers, you have GABAergic agents, and then you have those that act on different pathways, whether it's calcium channels and others. For those who want to review this more closely, this image here divides the various agents mechanistically and synaptically. We know the gabapentinoids very well. I'm not going to spend a lot of time on this slide, but basically binds to calcium channels and reduces calcium density, and then thereby reduces the release of substance P, and also provides inhibition of presynaptic GABA. It's used in postherpetic neuralgia, diabetic neuropathy, migraine, etc. And the dosing is usually 3 times a day with PRNs as needed. Max dose should be 3,600 a day, very max. The rest is renally excreted, so you're not going to get anything out of that. And of course, watch out for any renal issues in this medication, because that's how it's cleared. Pregabalin or Lyrica is another option in the gabapentinoid family. It's very effective for certain neuropathies. However, you have to watch out for sedation, delirium, etc. Interestingly, it's actually been used for anxiety management in Europe for many years. The FDA equivalent in Europe has approved pregabalin use in GAD. So you may be able to kill 2 birds with 1 stone with this medication if somebody has significant amount of anxiety. But you do have to do certain monitoring as listed there. Topamax or topiramate is a useful agent in headaches and some chronic low back pain. However, it is dose limited by the sedation and cognitive blunting or Dopamax effect, as well as other things like renal calculi. So please be careful. Carbamazepine or Tegretol has a long history of use in trigeminal neuralgia and other facial pain syndromes and paroxysmal pains, everything from tabes dorsales, MS, or even cases of herpes zoster, things of that sort. And it's ineffective in some other conditions. It has complex pharmacological interactions, including autoinduction of metabolism, so you have to watch for that. But there is a role potentially if you've exhausted other options. Its cousin oxcarbamazepine or Trileptal also should be considered. Again, these are not first-line agents, but maybe after others have been exhausted. They can be helpful also in managing other mood states. As you know, they have mood stabilizing properties. So once again, if you can kill 2 birds with 1 stone, you have an opportunity. You do have to be careful with some of the side effects, of course, of these meds. Lamotrigine is still another one. Believe it or not, it has a small role, a limited role in pain management, particularly in post-stroke central pain and other conditions like that, and certain neuropathies. As we all know, it's a pretty decent mood stabilizer if titrated appropriately. Of course, the usual precautions apply here. You have to go slow and start low to avoid Stevens-Johnson's. Valproic acid is an interesting one. We're very familiar with it in the use of agitation control or bipolar mania, but it also has a body of evidence in migraine prophylaxis and can be used actually to abort an acute migraine. You can give 500, sometimes even 1,000 milligrams IV times 1 rapidly. Sometimes that's done in an ER setting, for example. And the person doesn't need to be admitted or can be discharged more rapidly. There's some other mixed neuropathic pain conditions that might benefit from Depakote. But as we all know, Depakote has a number of side effects and problems and things that need to be monitored. Lithium, interestingly, doesn't have a large role in chronic pain. It has a large role in psychiatry, but actually in cluster headaches, it's been shown to be effective. So there's something about that pathology there that does respond to lithium. And as you know, it has strong anti-suicidal effects. So who knows, it could play a role, again, using the pharmacological creativity and understanding this, the psychiatric priority. It could play a role in some of your chronic pain patients, even at low doses, to forestall some severe catastrophizing or pain-related SI, something to consider. Antipsychotics are not traditionally used in pain management. That being said, there is some evidence that particularly the atypical antipsychotics may have a role. So let's review them. As we know, antipsychotics are divided into typical and atypical, and atypicals have more heterogeneity to the receptor action, as you know, more neurotransmitters affected. For pain, the dosing is much, much under that is used in psychosis and bipolar disorder. You want to consider comorbidities in informing your decision to use an antipsychotic, like mood, anxiety, sleep disorders, things like that. For example, olanzapine at most 10 milligrams or spaced out as listed here. Quetiapine, maybe 25, 3 times a day. Again, this is off-label pharmacological creativity that could help your patient. The problems are the same as with every other use of antipsychotics: weight gain, metabolic syndrome, QTC prolongation, etc. Our review that we did of atypical antipsychotics in chronic pain showed that really the only one that stood out as having some evidence and in specific pain syndromes was olanzapine or Zyprexa. The others are ineffective or have too few studies really to support their use. And olanzapine, in our recommendations, should be used only as an end stage adjunct after other things have been assessed. So in this flow chart that's in our article, you would be asked to assess the pain divided between neuropathic versus some kind of central sensitization syndrome, see if other things have failed, including TCAs and SNRIs and other psychological strategies, then see if there's psychiatric comorbidity, and then finally add an adjunct atypical, perhaps olanzapine, with low, slow dosing, PRN versus scheduled. If you follow this algorithm in certain patients, not many, but in some, you will see dramatic positive findings. And that can make or break a case. The other class is sympathetic modulators, medications that act on alpha and beta receptors. Interestingly, the adrenergic system is implicated in many pain syndromes, but the most familiar example is that of complex regional pain syndrome or reflex sympathetic dystrophy, as well as some comorbidities to pain like PTSD, anxiety, and panic. So if you conceptualize a dysregulated adrenergic or sympathetic system, then why not use sympathetic modulators for that pathway? A heightened sympathetic nervous system results in increased attention and vigilance to symptoms and will lead to poor sleep, unrefreshed to then deal with pain, kinesiophobia or avoidance of movement secondary to fear, all these various downstream effects from an uncontrolled hypersensitive sympathetic nervous system. So you might consider propranolol, clonidine, etc. Prazosin or minipress or catapress, excuse me, for nightmares is good in PTSD and can also be used in these conditions. Of course, you're going to have to watch cardiovascular side effects, hypotension, orthostasis, things of that sort. And finally, the last class of medications is Suboxone or buprenorphine naloxone, which of course is used in opioid use disorder and in medication-assisted therapies. There's a little bit of evidence to suggest that maybe it's also helpful for pain. So if you have somebody with an opioid use disorder and chronic pain, not a bad idea to try to induce them, start them on Suboxone, maybe maintain that over time. There's a little bit of evidence from this study, 54 folks who were compared with methadone over a 6-month period, and there was a significant difference in pain relief for both buprenorphine and methadone. Of course, methadone is a pure opioid agonist, so you would expect that. But a mixed agonist-antagonist like buprenorphine naloxone might not expect it, actually do see it. And then in a follow-up study of folks with chronic non-cancerous pain and opioid use disorder were switched from a full agonist opioid with very high morphine daily equivalents to Suboxone, to buprenorphine naloxone, and they saw various positive findings, not only with cravings and pain, but also with depression. You can see the p-values on the right. It may be that we're just treating a variant of opioid use disorder in these cases, but We need more information and more time as Suboxone becomes more and more prevalent and more accepted in the MAT community. Maybe we'll learn more about it. So I've sped through a lot of medications and a lot of things. I will summarize by suggesting that you need to differentiate chronic pain and acute pain. Consider the biopsychosocial targets in chronic pain, whether that be ongoing central sensitization and neural enhancement, or its psychological features or pain experience, or maybe it's social variables, environmental variables. So it's very different from addressing acute pain where you just approach with traditional analgesics. Consider the actual summative experience. Is there fear? Is there anger? Is there depression? Is this more akin to a PTSD model? Understand your pathophysiology, central sensitization, your PTSD, pain psychology in terms of the essentials of understanding that. What is the treatment priority? I would argue that in many of these cases, the treatment priority should not be analgesia, actually. It should be detox, it should be MI, it should be psychopharmacology, it should be treating chronic psychiatric disorders that have taken a backseat and are informing the current presentation. And for a variety of reasons, stigma, other reasons, the person's not getting it addressed. And it's your job actually to try to convince them that it's important for their pain relief, actually, meeting their agenda, that they should have those psychiatric concerns managed. Explore the psychopharmacologic options with creativity and confidence. I would argue that CL is mostly all off-label psychopharmacological creativity. So why not here with pain? And CL psychiatrists are used to doing off-label prescribing. That doesn't mean that we need to be reckless or could be reckless, but it means that maybe we're the best equipped at doing that as opposed to our colleagues in outpatient psychiatry or even inpatient psychiatry. So ask yourself, how can I apply this sort of creativity, but also confidence in these meds that I know well in your chronic pain patient? And pair your interventions as much as possible with physical and psychological rehabilitative efforts, including interdisciplinary chronic pain rehabilitation programs like the IOP I briefly mentioned, which I can't get into today, but is essentially a partial hospitalization for chronic pain patients. If you find one of that sort, there are a few, but each region has approximately one, then you can refer intelligently to those providers. They usually are very equipped at assessing all of the hesitations that a patient may have at coming off of opioids or confronting movement or addressing their depression and anxiety. They are used to that and have kind of a built-in MI or acceptance and commitment therapy angle that they can approach these patients with. So if you as a CL psychiatrist don't have the bandwidth or the ability to do it, maybe just convince them to do that first step, get evaluated at a place that does see chronic patients like this, elevated interdisciplinary chronic pain rehab programs, and you can look those up on the internet based on your region. Finally, it's very important for you to neurovalidate, that's a word, a neologism of mine, but neurovalidate your patient. Validate that this is a medical neurological process, that chronic pain is something that is mediated through spinal cord and brain changes. Invite them to look at this as medical, because that's the way you're going to buy their confidence, and employ MI and other strategies to win them over and then help them with their agenda, but helping that agenda change from monolithic pain control. It has to be about more. These are my references. You're welcome to review these, of course, and you're welcome to contact me anytime if you have any questions. Thank you for your attention.
Thank you everyone for joining. I'm going to be giving the ACLP updates on perinatal psychiatry and women's health. I'm going to be focusing in particular on these recent times where we have had so much attention raised to the mental health impact of COVID-19, of healthcare disparities that have been spotlighted by the pandemic, but of course were in existence for many years prior to that, and our maternal mortality crisis, not necessarily in that order. My name is Priya Gopalan. I am the medical director of the Psychiatry Consultation-Liaison service in Pittsburgh, and I'm also the chief of psychiatry at McGee Women's Hospital. I have no disclosures. And for the next 30 minutes or so, we're going to be talking about a wide array of topics related to perinatal psychiatry and women's health. In particular, we're going to be talking about the maternal morbidity and mortality crisis that we face in the United States. We're going to be talking about clinical challenges associated with perinatal mental health care, And I'm going to be focusing in really on medication discontinuation, because this is an area that we really don't talk about very often. And I think we really need to be more aware of this. I'm going to be talking about COVID-19, of course, and its effects on women's mental health. And as part of that discussion, talk really about healthcare disparities in women's health and perinatal health. And then we're going to wrap up with a little bit of a review on some of the newer antidepressant medications, in particular, the rapid treatment meds that we have now. This graphic is from the Maternal Mental Health Alliance, and it represents the 1 in 5 women who go through any kind of perinatal mental health condition. So that data comes from the World Health Organization. And I think it's important to note that they actually tell us that there are groups of individuals who are at higher risk of mental health conditions in the peripartum period, and in low-income countries and certain populations, the rates might actually even be higher than this. But I think this is important for us to all be aware of. So the CDC has put forth a report on from 9 maternal mortality review committees. And I think the really important takeaways from this report is that mental health conditions are actually on this list as a leading cause of pregnancy-related deaths. In case you're not familiar with the definitions around this, pregnancy-related deaths is actually a pretty stringent way of defining a death in pregnancy. So, it's defined as, a cause that comes from something very specific to the pregnancy itself. So something that is physiologically attributable to the pregnancy state. So the example that they give is eclampsia. Pregnancy-associated but not related death is another way of defining pregnancy deaths. And what that is defined as is the death of a woman while pregnant or within 1 year of termination of pregnancy from any cause, which is not a cause of pregnancy or illness exacerbated by pregnancy. So in other words, it's not physiologically attributable to pregnancy in the way that preeclampsia maybe is, but is something like motor vehicle accidents that occurs during the peripartum period. So this is important to sort of delineate, because while mental health conditions were already on the list of leading causes of pregnancy-related deaths, we are getting more and more data on pregnancy-associated deaths. This report was published just at the end of last year. This is for the state where I practice in Pennsylvania, and looked at pregnancy-associated deaths between 2013 and 2018. And the data here, and I really want to emphasize that this is consistent with data published across many other states as well. But I really want to draw your attention to the fact that the leading cause of pregnancy-associated deaths, and many of the ones in the top 10 here, are directly related to mental health. So accidental poisoning, so things like substance ingestions, drug overdoses, intentional self-harm is on this list, which is actually a pretty big one. And then assaults are on here. So these are things that are very adjacent to mental health, if not directly related to psychiatry itself. And these are in the top 10 for pregnancy-associated deaths. So this is clearly, something that we need to be paying attention to. So I'm going to transition us to talking about a case. So Miss A is a 28-year-old female who's a G2P1 who you see after an admission to the obstetrical hospital after a positive pregnancy test. She presents to you at approximately 10 weeks gestation. She reports to you that this was an unplanned, wanted pregnancy and that she has limited supports. She has no significant past medical history, but she does have a psychiatric history that's significant for postpartum depression after her last pregnancy and one other depressive episode that was a little bit more remote in her teenage years. She denies the use of any kind of substance to you. So you do your evaluation, you refer Miss A to a perinatal psychiatry clinic for counseling due to her psychiatric risk factors. And as you're wrapping up your consult with her, she mentions to you that she had actually been on fluoxetine, 40 milligrams daily prior to her pregnancy, but she stopped this medication about 2 weeks ago because she was worried about medication use in pregnancy. And I want you to take just a quick pause to think about this kind of scenario. You've probably encountered it clinically before. And I want you to think about what types of strategies you might use on her. Are you going to restart her fluoxetine? She's been off of it for 2 weeks. Are you going to maybe just sort of let it ride out and see how it goes? And what sort of practices have you seen done in the community that you work in, whether it's by PCPs, OBGYNs, psychiatrists? Are you seeing people who are kind of restarting or discontinuing? And before I start talking about these different pathways, I do want to highlight that this was published this year and looked at prescribing practices in pregnancy from 2005 to 2014. And I just wanted to kind of highlight here that that top line is the number of individuals in the United States who are prescribed any SSRI during pregnancy. That number is fairly high. It's over 4% of individuals who are pregnant in the United States who are prescribed any SSRI. And I say this to not only highlight this as a recent study that was published, but also to say that this is an opportunity to use this data to normalize and validate the use of medications in pregnancy if it is clinically appropriate to do so. But what I really wanted to point out, and this is an older study, but what I really did want to point out here is that there is actually a cost to medication discontinuation. So I'm going to orient you to this graph for a second. On the x-axis, you have weeks of gestation from left to right. And on the y-axis, you have the proportion of individuals without a relapse in their depressive episode. So that top line, the maintained line, are the people who stayed on their medications during pregnancy. Actually not as flat as one would want it to be, but it is the individuals who stayed on their antidepressant medicine, on their SSRI during their pregnancy. The line at the very bottom are the individuals who have discontinued their medications and stayed off their medications. So you can see a couple of things here. First of all, there's a 5 times increased risk of relapse if you discontinue your medications, and that this, out of the people who discontinue their medications, their depression really recurs by the end of or at least by the 2nd trimester. And this is important because then you have individuals who are not only probably exposed to medication sort of in that early part before they knew they were pregnant, but also exposed to depressive illness itself, which in and of itself is a exposure. Now, if you look at that middle bar, the sort of dashed line in the middle there, I think it's important to realize that this is the group of individuals who stopped their medications, but then reintroduced it at some point during the course of their pregnancy. So you can see that that line tracks much more with the individuals who stop their meds as opposed to the ones who maintain their medications. There is parallel data. This is also a little bit older on lithium, where we can see that people who stay on their medications really do much better than the ones who discontinue their medications in terms of recurrence of their psychiatric illness. But I think what we are discovering, and this is where the sort of more updated information comes in here, is that discontinuation of medications actually is a much more complicated story than we probably thought previously. This is a study of 25 patients with ADHD. Granted, this is a very small sample size. It is a recent study where they were prescribed stimulants, and the different colors on the graph here, the blue line is medication discontinuers for stimulants. People who had dose adjustments, which is the red line, and then the green line are the people who stayed on their medications. And what we see here is if you stop your stimulant when you have ADHD during pregnancy, the bottom graph here tells us that people don't do as well. So their level of functional impairment is worse if they stop their stimulant. The top graph actually looks at EPDS scores. And in this group of individuals, their antidepressant dosing didn't change. And yet their EPDS scores are actually going up when they stop their stimulant. So I think what this really tells me is that this is a really dynamic time period where we really need to be thinking very holistically and thinking about care as a whole, as a very complex sort of interplay. So Miss A was restarted on fluoxetine at 40 milligrams daily. She sees your colleague at 30 weeks gestation, the person you referred her to, and tells that individual that her depression has recurred, that she's not feeling as well. She is really worried about postpartum depression. She notes that her first postpartum period with her now 3-year-old was really difficult. She had significant challenges with bonding with her newborn, and she really wants to do whatever she can to avoid this scenario if she can, but at the same time is also worried about dose increases. Maybe she'd heard that that she should stay on the lowest dose possible during pregnancy. Maybe her PCP told her that, but she's just really, really worried about increasing the dose of medicines during her pregnancy. And I want you to sort of think about this scenario as well, because I'm sure it's something that a lot of you have encountered before, and to really think about how to advise Miss A in this particular clinical scenario. And I want to draw your attention to this article that was published within the last couple of years. So this particular study looked at the impact of antidepressant use during pregnancy and really stratified the group of individuals in the study by people who were on antidepressants at the beginning of their pregnancy but discontinued their meds. And there were 38 people in that arm. And then they look at the people, they look at 180 individuals who used their antidepressants throughout their pregnancy, but they actually split that further and pulled out the 46 individuals who actually modified their antidepressant dose versus the others who stayed on the same dose throughout their pregnancy. They adjusted for a lot of confounders, and compared to people who are not on any antidepressants, the individuals who discontinued their medications were at higher risk of depression. So this is not terribly surprising, but it's something that's worth noting. I think the point that is even more remarkable, though, is out of the people who stayed on their antidepressants, if they didn't have a dose adjustment, they were at almost five times greater risk of depression by the second half of their pregnancy. So there is really something to be said about being dynamic and patient-centered in medication management during pregnancy. And Ms. A was really quite right to worry about impact on the mother-baby sort of dyad and bond. The study came out within the last couple of years, looked at the association between maternal perinatal depression and anxiety and child and adolescent development. And this was a meta-analysis that pulled together 195,000 mother-child dyads. And what they found was that perinatal depression and anxiety in the mom was associated with poor offspring development across multiple domains: social, emotional, cognitive, language, motor, adaptive behavior, really a wide array of different domains. And that these findings extended for a pretty long time. So it went beyond infancy into childhood and even adolescence. Now, I say this with a little bit of caution, because what you don't want to do is blame and shame the moms that you're working with, especially the ones who opt not to take medicines or, opt not to follow the recommendations that you give them, but to really just use this information as a way of educating the parents, the mothers that you see. And I think it really helps to sort of emphasize that we have shifted quite a lot in the field over the last few years. Now, of course, there were some centers who are far ahead of the curve in their conceptualization of dyadic care, but I think it's important to be able to educate yourself and educate the parents that you work with that, perinatal depression, perinatal anxiety really is a family disorder. It is one that not only affects the mother, it not only affects the baby, but it has, multi-generational implications. It has epigenetic implications. It has neurobiological implications, and that's worth stressing. And as a field, I think many places are shifting as a result of that towards more dyadic work, towards fields like infant mental health. I put up a graph here of circle of security, which is one particular school of thought, or one particular treatment modality for addressing the family unit as a whole, which I think is really, really important to keep in the back of your head, because pregnancy does remain a window of opportunity for healthcare. It's a time where parents are very, very motivated for change. And as part of that conversation, I think it's also important to note that studies to this day, despite the known sort of limitations, do sort of follow this case control format. So a lot of the headlines and things that you're going to be reading about on Medscape compare a group of individuals who are not depressed and not on medications to a group of individuals who are depressed and on medications. And this is really an apples to oranges comparison. And the reason for that is that it leaves out a really important group. And that important group is that depressed patient population during pregnancy who are not on medications. So, I say this to encourage people to be very discerning as they're reading through the studies on this, and understanding that no matter how many updates we have and how much data we have, that we still have these inherent limitations. And I'm going to make a really bold statement in saying that in the vast majority of studies on medications and pregnancy, when they are well constructed, when the confounders are accounted for, including things like making sure that the sample you have is on antidepressants or whatever class it might be for the indication, for the psychiatric indication that it's used for, associations that were previously found tend to disappear. So with that, let's go back to Miss A. So at her next visit, Miss A shares that her depression has improved. She's experienced some increased anxiety around the COVID-19 pandemic. She wonders if there's a connection between COVID-19 and increased depression or anxiety. She notes that many of her pregnant friends are also struggling with the same kind of anxiety. So again, I want you to think about what you could tell her beyond probably what is very obvious to you all, which is, the obvious answer of yes. But I think, you are all probably quite aware of this, but the prevalence of depression symptoms during the pandemic have really gone up pretty significantly. It's a threefold increase based on studies that have been published to date, and that there are some differences in gender with these numbers. So women are more likely to have depression symptoms. This was a little bit true pre-pandemic anyway, but the pandemic has certainly highlighted that. So if you look at the numbers here, we go from a baseline rate for depression symptoms of 10% up to 33% for women during the pandemic, and for men, about 7% to 21% is based on this one study. We know that the impact of COVID-19 has been pretty significant in terms of perinatal mental health. This was a questionnaire study that was done during the pandemic, or during the last year, I should say, that looked at anxiety and depression scores. It was remarkable in that there were a large number of individuals who reported anxiety symptoms, and a large percentage of individuals, between 30 and 40%, who reported depression symptoms. These rates were much higher than pre-pandemic rates, which were reported to be about 3%. So I think this is really important to know. This is a meta-analysis that was done. They looked at 23 studies, 20,000 participants, and looked at prevalence rates across multiple symptoms. And they found, I thought these numbers were quite staggering. So 70% with psychological distress, 37% with anxiety, 31% with depression, kind of in line with that other study, but 49% with insomnia and 22% with postpartum depression. So this is a pretty big deal. These are really, really high numbers. So we have an acuity that is quite high right now, and I'm sure you're all experiencing that clinically as well. So, again, we know that health risks and outcomes are disproportionately affecting our population here. This particular report looked at just worry and stress. So instead of kind of pathologizing, thinking more about, what are you worried about? And they asked a bunch of different questions. Are you worried that someone in your family will get sick from COVID-19? Are you worried about lost income? Are you worried about exposure risk, or the ability to go into work or not? Are you worried about affordability? Are you worried about the impact on your mental health? And it turns out that women were worrying more than men across almost all of these domains. So there are definitely some differences here when it comes to women's mental health. And as part of this conversation, and of course, acknowledging that not all domestic violence happens to women, but this is an area that preferentially does affect women. This was an article that was published a year ago, a little less than a year ago, on trends in domestic violence calls. So this particular study looked at police data from stay-at-home orders. They picked a very sort of geographically diverse group of cities. So, they really picked cities from across the country. And what they found is that the percent increase in domestic violence calls went up across all of the cities that they looked at. So, the smallest increase was 10%, and that was in New York. But, you see Portland and Jefferson, Alabama, with numbers that are well over 20% in terms of percent increases. So this is alarming. It is also something to really keep on your radar as you do your evaluations, to screen carefully for. So Nisei was admitted for induction of labor at 39 weeks gestation. And she reports to you that her depression remains improved, but she has a few concerns for you. And out of these concerns, she really wants to ask you about healthcare disparities, especially in regards to postpartum depression, because she had heard something about this before. So again, I want you to think about this. And I will say, from a clinical standpoint, I experienced this much more frequently than I expected to at the obstetrical hospital where I work at McGee. I get asked about these sort of discrepancies and disparities often. And the truth of it is, compared to white women in the United States, a Black woman is 12 times more likely to die from pregnancy and childbirth related events, which is sobering, but they're also more likely to die from coronary artery disease, from hypertension. You can see the increased risk here is much, much higher than we would want it to be. So this is all data to kind of keep in the back of your head. This is true across populations, not just specific to peripartum ones. So trends in breast cancer incidence is, I think, interesting, really interesting, because, and this is not my area of expertise by any means, but if you look at this graphic here and look at the years, the y-axis here is cases per 100,000 females. And you can see the actual number of cases initially started out with Black women being diagnosed or having lower rates of breast cancer. And over time, those gaps have sort of narrowed. So we have about 41,000 deaths in breast cancer because of breast cancer each year. But I think the part that's really, really staggering is that breast cancer mortality rates are much, much, much higher, 41% higher in Black women. And this is really, really something that we all should be taking note of. In relation to peripartum mood and anxiety disorders, Black mothers are much more likely than white mothers to experience these perinatal mood and anxiety disorders. And, there are a number of risk factors that go along with that. So lack of access to care. We talked about higher risk and more complications in terms of healthcare disparities. So this will certainly impact pregnancy as well. Lack of social supports, just gaps in access and for many, many different social determinants of health type of reasons. But we also have more exposure to stress, to trauma, to systemic and structural racism. So there are a lot of factors that go into this. But the bottom line of it is that we have prevalence rates of postpartum depression in our Black and brown moms in the United States that are 3 to 4 times higher, depending on what study you're looking at, than white women. So you just have to be very mindful of this as you do your patient evaluations, and understand that there are some real big issues that arise from this. The first one being that we have our minority moms who are identified at lower rates, even though their incidence of these different conditions are really much higher. So that's obviously problematic. And that we really don't have great screening tools for this. Most of the screening tools that are validated out there are not validated or were not created with minority moms in mind. And I think the other thing to really remember is that if you're a Black woman who's not doing okay from a mental health standpoint, there may actually be a real cost to not doing okay and not being okay. Because we know that in our society here in the United States, CYF, Child, Youth, and Family Services, disproportionately removes Black children from their homes compared to white children. So, we have barriers kind of at every level from a system standpoint. So, you may have to be a little bit more active in outreach. Even if you took out some of the socioeconomic kind of barriers and variables, I think in some of these studies, it's important to note that in terms of initiation of postpartum mental health treatment, we have much, much higher rates, really double the rates of postpartum mental health treatment in white moms compared to our minority mothers. So I think it's really, really important to keep these numbers in mind. This is a little bit of an older study, it's from 2013, but more updated data has actually shown us similar disparities that continue to persist. So this was published in 2020 at the end of the year and looked at race and ethnic disparities in individuals who delivered babies where opioid use disorder was a part of the clinical presentation. They looked at 1,700 deliveries, and this was the breakdown in terms of race and ethnicity. And they found that there were statistically significant differences in the use of medications for opioid use disorder during pregnancy, and that this fell across race lines. So when compared to white women, Black and Hispanic women were prescribed medications for opioid use disorder at lower rates. And again, this was statistically significant. And more interestingly, that Black and Hispanic women were more likely to receive methadone than buprenorphine. And this is notable because methadone has a number of additional barriers to care that buprenorphine perhaps does not. So for methadone, you have to go every day. At least in our state, you have to have an ID card, you have to have transportation. It's a complicated process. It's a great medication, certainly. It's certainly better than nothing for many, many individuals, but to have these disparities and these discrepancies is pretty notable. So, I included a little bit on telepsychiatry here because I was thinking a lot about the COVID-19 pandemic and, thinking about, we have all these sort of issues and problems that have arisen in terms of access to care, in terms of healthcare disparities. And of course, telepsychiatry as a potential solution to some of the problems. Of course, it's not going to solve all of our problems. And we have great data in the general population for telepsychiatry in terms of outcomes and especially depression outcomes. But I think, I wanted to look specifically at the peripartum literature. And it turns out that we actually do have some data that tells us that telepsychiatry is a perfectly appropriate modality of care in the peripartum population. So this 2020 study looked at telepsychiatry specifically in integrated care settings. and they actually looked at some outcomes, which is really nice to see. It showed a 96% treatment engagement, which is fantastic, but also looked at some outcomes and found some positive outcomes in relation to ED utilization rates, which were low in the group that accessed telepsychiatry, and also higher breastfeeding rates. So this is certainly a positive. A little bit of an older study looked at meta-analysis of 8 different studies and found improved depression scores. So, we have some data to tell us that it is useful in terms of actually treating depression, but also good for other healthcare outcomes as well. So Say has a spontaneous vaginal delivery, no complications. You see her 6 weeks later, and she tells you that she's been having some difficulty with mood again, low mood, anhedonia, hopelessness, some difficulty bonding with her baby. She's remained on her fluoxetine, continued psychotherapy, but she asks you about these new medications that she's heard about, brexanolone and zuranolone. So I don't know if anyone's put anyone who's listening to this on the spot with these kind of questions, but I thought it would be worthwhile to talk a little bit about these medications so that you're familiar with them. And you've heard about brexanolone before, I'm sure, both through this course and in other settings, but it is the first medication that was FDA approved for postpartum depression that happened a couple of years ago. It is a neurosteroid treatment, and it is a medication that shows rapid response in terms of depression treatment. So it is given as a 60-hour infusion, and it does require medical hospitalization, and we'll talk about that in a second. Phase 2 studies showed a very early response and a really wide response. So compared to placebo, 12-point difference in HAM-D scores. But larger phase 3 studies showed a smaller, point separation, but still a sustained response up to a month. There is a black box warning on the medication that you should all be aware of. It is for sudden loss of consciousness during the infusion. It happened in about 4% of the patients in the phase 3 trials, probably because of the GABA-A mechanism that the medication has. Because of this, we do require hospitalization, and it does require monitoring for excessive sedation and loss of consciousness, and there is a REMS program that's associated with the medication. Hot off the presses, this was published just a couple of months ago, but zuranolone has been studied as well in this population. It is the oral form. It's the oral formulation of the medication. The phase 3 trial is what was recently published. It's multi-site study, 153 randomized patients, and it showed some pretty similar responses in terms of reduction in HAM-D scores compared to placebo. And not only similar to brexanolone, not only was that difference shown early, so that the differences in HAM-D scores were observed by day 3, but that they were sustained through the first month, which is important for an episodic illness. But the real reason that I mentioned this medication is because you are going to hear a lot about it. I suspect in the years to come, there are studies for it outside of pregnancy. There are studies for it for all kinds of different indications, such as insomnia. There's studies for it in other populations, like in Parkinson's. So I suspect you're going to hear more about this medicine as we move forward. The only other medication that I really wanted to put on your radar right now was one that was approved by the FDA in 2019 as a new treatment for hypoactive sexual desire disorder. And I mentioned this not because I prescribe it or anything like that, but because it is a new medication in women's mental health in particular. And it is, injected under the skin at least 45 minutes before sexual activity. So of course there's, there are some consideration and barriers around that level of planning. It was found to be effective in studies. So women who used it reported improvements in sexual desire scores compared with women receiving a placebo. But I think the one thing to really keep in mind is that bremelanotide was associated with some pretty significant side effects, including 40% of individuals reporting nausea with the first injection, which is obviously problematic. So to sort of wrap things up here, Ms. A sees you again 3 years later in the hospital after delivery of her third child. I don't know if others of you have encountered this scenario, but oftentimes I see people on our consult service across multiple pregnancies. And she tells you that, after her last pregnancy, she did receive brexanolone in the postpartum period. It had good effect. She engaged in an intensive outpatient program, and actually, that all brought her to symptom remission. She's had no depressive symptoms since then, including throughout her third pregnancy. And she was able to also stay on her SSRI and stay in therapy. So she was doing well. So I'm going to end with that and leave my email here in case anyone has any questions. Thank you so much for your time and attention.